Joe and the organizers. Like somebody mentioned earlier, this has indeed been a Herculean task. But the beauty of it is you guys won't realize if I'm wearing dress pants or pajamas when I do this, and I can do whatever I want to. I'm in my office, and I do have my door locked, so the BBC incident with the children walking in will not probably happen tonight. Now, are there any residents in the audience? I can't seem to see the. Yeah. How many residents in the audience? Try to. All right. I see Nate Spencer, one of my former residents in the audience. Hi, Nate. So we're going to get started, and I wish I could see. Can you guys give me the audience view of the actual audience as opposed to my slide? Is that possible? There you go. Thank you. And I lost that again. Okay, got it. More people in the audience now than I thought there would be, which was I was going to make the joke about some are teeth. You know, some are here, some are there. This will work out just fine. I asked the audience to be, the residents in the audience to be seated up front so I can pimp you guys and feel like I'm right at home. So there will be questions, and all the questions would have to be answered by the residents in the audience and not the oral and maxillofacial surgeons. I hope you guys are cool with that. I'm sure you're used to that. The title of my lecture today is rather long. It's basically a review of office-based anesthesia for those of us that don't like to read books and get an update on how things are, where things are. But primarily, it is something that I give at the ACOMS and at other board review courses with Dr. Steve Roser, who was one of my mentors. Dr. Roser and I have no conflict of interest related to this presentation, although we certainly wish that we had some. This is the University of Cincinnati's medical campus, and this campus basically is all of the medical center stuff over here. Is the little building over here is Holmes Hospital, where I practice and train. There is a certain culture in Cincinnati where people request to go to sleep, even to have a root tip removed from their mouth, and so it's we're used to providing multiple anesthetics in a day. Oftentimes, that means that our residents have to put some really sick people to sleep for the simplest of procedures. And that gives me a general idea of how the general practice works out in the real world, and I don't want to sit in an academic ivory tower and lecture to you about things that don't necessarily matter. The concept of this lecture today would be a meat and potatoes approach, and take home those things that are relevant to your practice and give you some updates on what is happening out there in the world of medicine and anesthesia. I made an attempt to avoid the rat facts, although your handouts, which you probably have a lot of rat facts in them. The lecture itself will not focus on any of that. So I just want to see if you could make a mental note yourself before the end of this lecture about what are the top 5 reasons that you would never sedate a patient in your practice. Top 5 medical reasons why you would never consider sedating somebody in your practice. In my practice, that would be somebody in the first trimester of their pregnancy, somebody who is extremely obese, somebody who's got multiple comorbidities, especially of the respiratory and the cardiovascular system. And I could think of children under the age of 5 or 6 that I don't feel comfortable sedating. And probably the 5th one is my own mother. I don't think I would want to sedate my mother because she'll find 5 or 6 reasons why I shouldn't have done that the way I did it. And that will be a really difficult thing for me to reconcile with at the end of the sedation. So at the end of the day, you need to have your top 5 reasons why you choose to never sedate somebody in your practice, and that, I hope, is the whole point of what we are going to talk about today. Medical management of our patients is basically risk management, and that comes with basic understanding of their medical issues and understanding risks associated with those medical problems. remember, the eyes never see what the mind doesn't know. So unless you know what the risks associated with certain medical problems are, you'll never be able to stratify risks for those patients. And what is important in that is that because it's such a moving target, the medications are different all the time. There's all kinds of new diseases that we are understanding better, and keeping current becomes even more relevant, and that means that there's a lot more we have to learn in any given day to deal with our complex patient population. What we're going to talk about today is essentially pre-surgical workup in the ambulatory surgeon's office. And that means that we have to understand and definitely deal with cardiac issues, pulmonary issues, GI issues, renal issues, endocrine and obesity related issues. And this is generally the outline of today's lecture. In the interest of time, we may not have the ability to go over things like hematological issues, but I'll try to hit as many points as possible. But understand that there is a nice, decent handout that you guys have, quite detailed with most of the rat facts, if you would, and we'll talk about what's practical to our practices. So let's talk about pre-surgical workup and how that is relevant to us. Are we good with the audio and the video so far? All right. So a lot of the current practice. By the way, I went and got this nice big mic. It kind of looks like R2D2. I hope this is worth the money I paid for it. A lot of the current practices use some form of a screening questionnaire. And OMSNC, if you're an OMSNC insured practitioner, for instance, has a decent screening questionnaire. If you're not, no worries, it's still the same thing, whichever one you use. And a lot of that goes through a medication list, and that medication list often yields a little bit more information than just the list of the medication on there. Printed and written pharmacy descriptions from the patient's pharmacy usually are useful, especially if you deal with a population like we do that is not usually aware of what exact medications they take. It's usually a heart pill, a fluid pill, an aspirin maybe, something for the arthritis, something for my blood pressure, and something for my diabetes. And you definitely don't know the details of any of these going forward. But then if you ask targeted questions based on all of these things, usually you can get through your screening questionnaire and understand something quite basic about the patient's current medical systems. So for instance, if we have a 64-year-old type 2 diabetic who is managed with oral metformin and has a recent hemoglobin A1C of about 5.5, that's quite decent, with a predictable mild exertional angina that presents for a close reduction of a condylar neck fracture. So the issue is you can't avoid this, you can't send it off anywhere else, and you'd have to deal with this patient yourself. How are you going to deal with it? And first of all, what is his ASA classification? So if you think of it as somewhat of an emergency, is it a 2A, or 2E, a 3, a 4E, a 5? Which of these do you think would be the ideal ASA classification for this patient? Anyone? I would think it's a 3, and I'll tell you why it is a 3. So if you look at ASA classifications according to this chart here, a 3 is somebody that has severe systemic disease, somewhat of a functional limitation, and has a controlled disease of more than one body system or a major system. If you thought the patient was an ASA 2, you're just being a little bit more optimistic. The patient does have a predictable mild exertional angina-like symptom, and so that's definitely giving them some functional limitation. His diabetes appears to be well controlled, so it's a controlled disease of one or more body systems, and the rest of it kind of falls into place accordingly. So this patient would be an ASA 3, and how many people would actually consider treating this patient in your office, considering that the procedure itself is actually quite quite benign in what we would do. Would you consider treating this patient in your office, or would you take this patient to the operatory and make somewhat of a risk stratification, saying, I'd like the anesthesiologist to be the one managing the anesthesia as opposed to me, in case this person does have angina in his chest while I provide some anesthetic? It's that the problem with ASA classification system is that it's rather vague. It has a lot of overlap of categories, and the medico-legally necessary risk stratification kind of mandates us all to go through this. Now, in your current office note, if you are not noting the ASA classification system for all your consults, you should probably consider doing that, because that's because it's important medico-legally that you show some evidence of risk stratification prior to provision of surgery or anesthesia. It has become mandated in almost every risk management seminar, and if you go to those, they'll try to beat this horse to death about trying to get ASA classification for every single patient that comes your way. Now, there are other classification systems, and I see that somebody is trying to chat with me, but I'm not quite sure if that is from this system. Anyway, sorry, there are other complex systems, and the Europeans use their own system. There's an AHA classification system, but none of these are necessarily superior to another, and since most of us are used to ASA classification systems, it's probably best to stick to one uniformly across the board and just plan on doing that. There we go. So pre-surgical anesthesia testing is somewhat mandated in the operatory and in the hospital setting, but how practical is it to take it to our general system of management and how we do procedures in our office? How often are we sending our patients out for pre-anesthesia evals and getting lab tests? And there is a practical advisory that came out. Actually, there's an update that's coming out next year on this particular, from this particular task force from the ASA that looks at pre-anesthesia evaluation. Anesthesiologists are also turning their attention to what is considered ambulatory anesthesia. They have realized that that seems to be the way to go with a lot of the ambulatory anesthesia centers that are popping up. And so they are kind of adapting what we do, except they have their own models, and so this becomes quite important for them. The content of any pre-anesthetic evaluation includes stuff that, you know, makes it easier with the electronic health records these days, which means that anyone can access medical records. Now, in the city of Cincinnati, for instance, there are 5 major hospital systems. They all have Epic, which is our big electronic health records, but they all have different Epics. So it doesn't necessarily mean that I have the ability to look at somebody at Christ Hospital or Mercy Good Sam hospitals to on their Epic record through my Epic record, but there is an ability to somewhat connect and connect with care everywhere. So there is the readily accessible medical record that has made it somewhat of an easy deal these days, but the patient interview remains the most important thing. A directed pre-anesthesia exam, this is what we necessarily do in our practices. So while we're not necessarily doing a lot of pre-anesthesia evaluation like the anesthesiologist does, our basic consultation visits do the necessary for this particular task. So the patient interview, the direct pre-anesthesia examination, any kind of preoperative test when indicated. So this is when we don't necessarily always get chest x-rays and EKGs on somebody that we need to sedate to place a single implant. But the anesthesiologist would not hesitate to get that. And so is our practice somehow, when compared to theirs, under par, or are we okay with the way that we perform what we do in our setting? Other consultations when appropriate. Now this we do well because we do send a note to their primary care provider if we need to. We do send notes to cardiologists if we need to, and oftentimes OBGYNs if we need to. But then the response usually is a small scribbled note that says cleared for surgery, and they don't understand what we do, what the depth of anesthesia is that we provide, and things like that. So it's not usually practical in our sense if you consider consultations. At a minimum, a directed physical examination, pre-anesthetic physical examination, including assessment of airway, lungs, and heart. So if you can't remember when you last used your auscultative abilities and your stethoscope, you should probably consider using your stethoscope for all your pre-surgical, pre-sedation consults on a regular basis. It's important also to document in your current practice the assessment of airway according to what we will discuss here in the future, and also the lung and heart exam. Very important. Routine preoperative testing is not necessarily indicated. So the days have gone definitely where we used to check everyone's hemoglobin and hematocrits and white blood cell counts or anything routine. There's no need to do that unless, of course, there's a medical history of the physical exam that warrants it. The selection and timing of specific tests cannot be supported in any of the current evidence. That brings up practical issues, though. For instance, which test is usually appropriate for an otherwise healthy 19-year-old sexually active female on oral birth control medications prior to removal of her third molars? Are you going to test her for her serum beta HCG? Are you going to get a CBC? Are you going to have the ability and the capability and the intent to test her urine beta HCG? Or are you going to do any of this or none of these? I don't know about your practice, but I certainly don't get a urine beta HCG in my practice. But the question remains, what would be the appropriate testing that we should do? The true answer is there is really no right answer. There is no consensus. And assuming that a detailed preoperative evaluation was done, including questioning about menstrual cycle was performed, perhaps that's good enough for us to consider doing nothing at all. So if the patient did give us a history of not having a recent menstrual cycle and you're under suspicion that they might be pregnant, then perhaps getting a test is more prudent. But in normal circumstances, I don't necessarily believe that that's right or necessary. So what are the current CMS guidelines? System where CMS holds us hostage to almost everything that we do, including what we have for lunch. Then there is somewhat of it becomes of a habit that you do get H&Ps 30 days prior to an operation, even in an outpatient procedure. Now, this does not necessarily become very practical in my private practice, if you would. I don't have a private practice, but if I had one, I would suggest that, you know, if a sibling comes along with his brother who is here today, the brother is here today for a consultation for third molars, but the mother brings the younger sister along because she knows that the sister needs to have her wisdom teeth taken out, and they're not going to do anything now, they're going to do it in the summer. But is that okay to do a consultation at this time and then schedule her surgery out for the summer? Because we know the summer is going to get all booked up. And so I would like to get you on the books now, and I would like to see if we can go ahead and book an appointment. But since you're here for a consult now in March, it's okay. You don't need to come back for a consult. Is that considered an H&P before an operation in an outpatient procedure? CMS would tell you no. CMS would ask you to do an update of that H&P, and that becomes a little bit more relevant if you are in a setting like mine, or if you are under CMS jurisdiction. Pre-anesthesia evaluation by an anesthesia provider is required according to CMS guidelines within 48 hours of surgery, and that means that a nurse will call. That means that a nurse will call and ask you about your general health condition, if anything has changed, and we certainly cannot afford to have that in our practice. So are we, again, not necessarily up to par with what the anesthesiologists do in their practice? Is our practice of anesthesia somehow not safe enough because we don't do these things that CMS makes us do? That's not necessarily true, and we'll go into that here in a minute. components of the exam, testing, etc., is left usually up to the discretion of the surgeon or the anesthesiologist, even in the CMS guidelines. But the ASA guidelines that were published and usually updated every 4 years, so the next one's due to be out soon this year, they do require things that we usually do, and we usually tend to adapt these. So I am an author for the Office Anesthesia Guidelines for AMIS and the PAR Care document, the Parameters of Care document, and we just redid the Parameters of Care and Anesthesia section, and it'll be coming out this year. And we typically, what we do is we adapt these ASA guidelines, including these minimum pre-op exams, which usually consists of airway, cardiovascular, and pulmonary exams. Any catch you can get about the higher severity of disease, the high invasiveness of surgery, and things like that, that should somehow be caught ahead of the day of surgery. And then, of course, the opposite is true. If you do catch that it's just going to be a couple of extractions and the patient has well-controlled diabetes, that exam can potentially be done on the day of surgery as well. Well, what about pre-surgical anesthesia testing? So if you think about all of what we talked about and extrapolate the differences between an in-hospital anesthesiology testing versus an in-office oral maxillofacial surgeon anesthesia team model, what are we left with? I think what is true is that guidelines are often institutional. So regardless of what ASA tells us to do or what CMS tells us to do, it usually is up to some anesthesia committee or your own comfort level, and you usually form common sense guidelines. There's nothing wrong with that. Guidelines, after all, are guidelines and not necessarily mandates. The cost factors into that, of course there's the individual's cost associated with that, there's a societal cost associated with that, and there's all kinds of issues other than cost associated with it as well. So again, if you think about that one patient that we talked about, which test is necessarily appropriate for that 19-year-old sexually active female who's on birth control medication prior to third molar removal, are we truly going to send out a serum beta-HCG? Any of the residents in the audience know that's foolish because that takes like a day to return, and oftentimes that's not cool. There's no point in really ordering a CBC because we're not going to necessarily find anything associated with this patient that we need out of that. Urine beta-HCG can be done in the office, of course, if you have a suspicion for that. Of course, it's nothing wrong if you do choose to have none of these tests done, provided the question about about the last menstrual cycle was appropriately listed. So in the oral maxillofacial surgery setting, what are the pre-op tests that we need to order? Obviously, it doesn't matter what setting you are in, it needs to be based on risk factors. And the risk factors have to be based on age, ASA classification, and of course the surgical classification. And Turbot Fatahi, who is the chair of oral maxillofacial surgery at University of Florida in Jacksonville, when he was a resident, came up with this nice article in the Clinics of North America. It's about 10 years old now, but it's still relevant to what we do on a regular basis. He looked at preoperative lab and diagnostic testing and what is needed and when as it pertains to our specialty and our practice of oral maxillofacial surgery. And Fatahi came up with a surgical risk classification system, which I think is quite practical. So category 1 is something that we do which poses minimal risk to patients independent of anesthesia, which is, the usual stuff that we do. Minimally invasive procedures with little or minimal blood loss, often done in the office setting. Biopsies, dentoalveolar procedures, not like a full mouth extraction with alveoloplasty in all 4 quadrants and things like that. That would be the category 2, which would be minimal to moderate invasive procedure, blood loss of, somewhere under 500 ml, mild risk to patient independent of anesthesia. And then the category 3, I would suggest that category 1 or 2 or somewhere 1.5, 1 3/4 is where third molars would fit or multiple implants would fit. And then there's category 3. Category 3 is where there's moderate to significant invasive procedure blood loss potential of 1,000 cc's, moderate risk to patients independent of anesthesia, maybe a genioplasty in the office, maybe a bilateral sagittal split osteotomy, maybe an arthroscopy, an arthrocentesis, something like that. And of course, category 5 would be if you're planning to do something like a neck dissection, highly invasive procedure, major risk to patients independent of anesthesia, airway involvement, etc., including blood loss. So that is Fatahi's thoughts about surgical risk classification systems. But then he thought about, what do I do as far as routine pre-surgical tests, and how can I do that based on category and ASA classification? So he thinks that if you're in an ASA 1, category 1 surgery, male, essentially no tests are required. Female, childbearing age, consider beta-HCG, again based on direct questioning and patient interview. Category 2 surgery, perhaps consider a CBC or at least a hemoglobin hematocrit and a chemistry. And in males greater than the age of 40 to 50, again based on individual interview, add perhaps an ECG to that, and all patients above the age of 60 add ECG and chest x-ray. And this, of course, we're talking category 2 surgery and in patients who are ASA 1. What about ASA 3 or 4? What about those patients? Maybe there is some value in testing some more routine labs and adding ECG and chest x-ray depending on their age. ASA 2 or greater, of course, the suggestion is labs is indicated based on medical history or physical examination. Nothing groundbreaking, nothing that we are learning new here. Unnecessary use of tests obviously increase costs and may not necessarily benefit. The problem, though, is that sometimes we find abnormals when generally the greater than 2 standard deviation from median value is what is considered abnormal, but oftentimes that has no relevance to what we're going to do for that patient clinically. And so then the question is, why do we even bother to test and incur those extra costs? Remember, if you order a test, the error of omission of not looking at that test results is much worse than the error of commission of having ordered that test. So if you did order something, you better look it up. And if it does have anything quote unquote abnormal related to it, you better address it. Otherwise, you're not going to be necessarily looking very good in a court of law if that is ever questioned. So it then brings out the question of the court of law, and where you practice what the general sense is and what everyone else might be doing around you. Are you the only guy in town who's not getting an ECG and chest x-ray on everyone above the age of 50 who needs to have any kind of procedure done in the office? If that is the case, there is a good chance that you're not necessarily practicing up to par with everyone else in the area. So then there is so much variation in this, and that is where the concept of common sense, like we talked about earlier, comes into play. There is, of course, the fact that just because everyone else is doing it, it does not necessarily make it evidence-based, and you don't necessarily need to continue to do that. Now, I know that when I say something like that, some of you are itching to ask a question, and Joe, I'm not sure if there's a way that they can interrupt me and ask a question at this time. So if there is indeed that, please let me know, and I will be happy to answer those questions for you. So if the ASA status of the patient is greater than or equal to 2, maybe there are some lab indications based on physical exam or medical history, and those are, of course, listed here. If the patient has had a major recent infection, if the patient's had some immunocompromise, if the patient's been on chronic steroid therapy, things that are listed here obviously make sense. Now, again, this is based on your patient's interview. This is based on what you find in your patient. So it's important that not everyone gets blanketed for common individual labs. Again, serum glucose, these are indications for patients, and as well as hematologic studies, and LFTs. Now, LFTs are important. The average patient may not come across to you as an alcohol abuser, and I'll give you an example of that. I share my practice in the operating theater here with a sports medicine doctor, an orthopod. And he is a picture of walking pink health. There is nothing wrong with his health. He works out every day. He is in his late 50s. He doesn't look a day older than 50. He is a sports medicine guy. He used to be a football player, and he looks and behaves like a football player, especially with the loud swearing in the operating theater. And what happens is that one thing I know, if I was going to treat him, is that he and his wife easily polish off a bottle of wine, sometimes 2 bottles of wine, every night between dinner and going to sleep. And is that person now putting their liver at risk? For instance, if he had to have 3 or 4 implants placed in my practice and he came to me, am I really going to get an LFT on him? Is he considered an alcoholic just because he doesn't exhibit signs of withdrawal or has any kind of delirium tremens associated with it? This is a guy that is consuming 6 to 8% alcohol, sometimes 15% alcohol daily, 7 days a week, at least 1 or 2 bottles for the last 20 years. And so is his liver function to be tested or not? And that is something, again, based on your interview, based on your patient. He may not be an unhealthy patient. It's probably likely that he doesn't have any visible hepatic disease. But this is also a guy that is his own doctor. He doesn't go to his primary care doctor. He doesn't get annual physicals done like the rest of us. We don't do that. We know when something's wrong with us. So what about UA? Do we get a urine analysis? Is that really going to change anything about what we do? Chest x-rays is something else. Random chest x-rays are gotten in the pre-op area by our anesthesiologist for the slightest of indications, but we don't get chest x-rays. Even if the asthmatic child that comes to our practice for having 4 premolars removed from their orthodontist has a recent upper respiratory tract infection, I'm not going to order a chest x-ray for that. I might send him back to his pediatrician and say, hey, can you work this kid up? And I might not choose to do that procedure that day, but am I truly going to order a chest x-ray in my practice? What about an ECG? Now, we hook out patients up to ECGs all the time, and so we do get a 3-lead reading, and of course we are all adept at reading that. If that's something that's indicated, and if that's something that needs to happen, we should get that, and we should be able to interpret the quality of that reading ourselves, and we should be able to cater our anesthetic plan based on the reading on the EKG for patients where it is indicated. University of Nebraska Medical Center, a lot of smart people work there, and they came up with what I call a practical hybrid pre-anesthesia testing guidelines. So this is something that a lot of it is done ahead of time by an RN that makes a phone call, 14 focus questions, and then they figure out if there's a need for testing or necessity for a separate pre-anesthetic clinical eval. The pre-anesthetic testing is based on comorbidities and not necessarily age-based. So if you are a healthy farmer in the Nebraska area that does, in Omaha, for instance, that is 70 years old but doesn't even take an aspirin, they don't necessarily base your testing based on your age. They check to see if you have any kind of functional incapabilities. And this, I feel, can be adapted for office surgery. This is probably one of the most practical things I've seen come through recently. And basically it gives a nurse or an assistant or yourself this checklist. And this can tell you if the patient has any particular questions, these 14 questions that they are asked. Do you have, or been told you have anemia, and the risk associated with the anemia, and of course the symptoms associated with the anemia, bleeding history, cardiovascular, you name it. Have you been on TPN feeding for any reason at all? Do you have systemic lupus erythematosus? Any of these can come up, and then they have a guideline by which they can figure out if somebody doesn't have anything at all, say for instance they had a UTI 6 months ago, I don't need to get a UA on them. It's not going to change my anesthetic plan for what I intend to do. So this can be adapted to the office setting altogether. So now we're going to talk about risk assessment and anesthesia risk assessment. And risk comes by all the time, and this is something that is questioned and under threat. As long as we continue to do office-based anesthesia in our current setting, in the current model that we practice, we will be questioned by people who could gain benefit from being in our offices. And so how safe is truly anesthesia provided by oral maxillofacial surgeons? This has been studied ad nauseum. Actually, this is Jeff Bennett's paper. Jeff Bennett looked at this in 2003. He found there were no complications associated with 99.6% of our local anesthesia procedures, and quite close there was our, at that time, what was called conscious sedation, what now we call moderate sedation. Of course, the deep sedation, general anesthesia, were 98.5% of the time we were delivering safe anesthesia. The office-based anesthesia, the parameters of the care and anesthesia manual, since the multiple iterations of looking at our own safety, etc., has come up with suggesting some of the things that we need, and that includes ventilatory monitoring, including auscultation using a precordial stethoscope and a visual capnography that the entire team can see, an IV catheter, which is not necessarily a butterfly you can put in there, but an actual angio catheter needs to be placed. In 2003, only about 50% of us were using an angio catheter. Only about 18% of us. I'm surprised that this probably was in Jeff Bennett's practice. Only about 18% of us were, there were 18% of us using capnography in 2003. And of course, a lot of us use stethoscope, and even to this day, I think that's a simple and effective tool. OMSNIC looks at this number quite in detail, and they have published their 10-year, 13-year here data. And we do those many office-based anesthetics, and only those many out of those many actually resulted in some kind of severe outcome, 1 per 300,000, 350,000 cases. But if you extrapolate that data into looking at how many do we do per week, how closely do we get to it, things like that, it actually once every 6 weeks or so there is a bad outcome in our practices. But accidents are normal and should be expected. When we live in a high-risk technology world and we take that risk, this is normal to have accidents, and that's been proven time and again. Of course, that's not what we want. What we want is safe care. And how do we do that? We do that because we have combination of things we have mastered. We know what we have in our offices. That equipment is brand new. You just picked it up at your last AMOS meeting, and you have the latest and greatest capnography. You have the latest and greatest monitoring equipment. Your patients prepared because you have seen them ahead of time. You have diligently looked at what their general comorbidities are and what will work for them and what won't work for them. You don't have a cookie cutter technique for everyone that walks into your practice. You have a team that prepares every day. You have a team that practices simulation scenarios every quarter, at least once or twice, and you have yourself. You are the best. You came through the best training program in the country. You practice the most safe anesthetic technique. You have no compromises on quality or safety of your patient. And you do always what is right for your patients. There's no ifs and buts about it. And that, of course, would be the ideal scenario in which that we provide safe care for our patients. The truth is that none of us are that ideal person. None of us have the ideal equipment. None of us have teams that are all set for emergencies, and none of us truly prepare the patients well for doing what we need to do. We become slaves to our technique. We become slaves to our routine. We look at ourselves and go, this patient's going to get my usual 5 milligrams of midazolam, 50 of fentanyl, and slugs of propofol. Maybe if I feel creative today, I might add a little ketamine to it. Maybe if I feel creative today, I might even leave the nitrous oxide on. I'm going to start that IV where I feel most comfortable. If I can't get an IV, I'm going to talk them into local. I'm not going to consider starting an IO or anything that can help me, rescue me if I need to. But let's talk about all of that. Can you truly assess an airway? Can you truly intubate a patient? Can you at least ventilate a patient? We're going to talk about all of these things. Airway assessment is basic. You all have seen these pictures. You know the class 1 when you see it. You know the class 4 when you see it. You think it's a class 2 when it's actually a class 3. You're going to talk yourself into believing that it's a class 2 when it's actually a class 3. You're going to try to talk the patient into opening as wide as possible to get 2 finger breaths or maybe 3 finger breaths, and you feel comfortable that they have an adequate hyomental distance and a thyrohyoid distance. The truth is that a lot of our patients are larger, bigger, and getting bigger and bigger. So if you took number 30 out on them this year, when they come for having number 19 taken out 2 years from now, they're going to be heavier. There's no ifs and buts about that. The change in emphasis has become, we've moved away from where we used to think, if you can't intubate it, don't sedate it. I think we should change that. If you can't ventilate it, don't sedate it. Difficult to intubate does not necessarily mean difficult to ventilate, but difficult to ventilate definitely means that it's really going to be difficult to intubate. Most studies do not really investigate the difficult to ventilate part of things, and the medical literature boasts of a plethora of articles discussing predictors of difficult intubation, but relatively a few of them explaining predictors of difficult mask ventilation. Approximately 15% or so of difficult intubations are also difficult mask ventilations, and that is a real problem because most of your patients are going to look like Hagrid. They're going to be big, they're going to have a big amount of hair on their face, they have a huge BMI, and some of them have no teeth. And they also snore. They're older. They have these skeletal abnormalities where they have a small maxilla, big mandible, poor atlanto-occipital extension, lingual tonsil hypertrophy. Makes it worse if they have heavy jaw muscles and a big tongue to add to that. And of course, you should throw in the fact that they all have obstructive sleep apnea too. So between all of that, can you truly ventilate that patient? Can your difficulty to mask ventilate a patient be prevented by having the patient shave their facial hair, for instance, or leave dentures in, for instance? I can tell you, my own face, I would probably be a poor ventilation candidate. I have a small jaw, I have facial hair, I'm getting fatter, and I have a large tongue, I snore, I probably have obstructive sleep apnea, and so I'm probably a bad candidate to be sedated in the office in the first place. Let's see what else we can find. What about a child? Remember, a child is not just a small adult. If you think about them, they actually look like Martians. They have a big head, they have a tiny neck, and they have big protuberant abdomens. Overall, just weird looking kids. Have you ever thought about how weird little babies look? And imagine if you took a pure Robin child, put him on his back and got a lateral view of his face. That's what they look like. Look at that tiny, tiny airway. There's no airway there. This is one of the patients that we got consulted on for a mandibular distraction osteogenesis. They were already trached. We were able to get the trach out. But overall, this is a child's airway, and we'll talk more about that this afternoon as well. Children alone are not the problem, but a geriatric airway can be pretty bad as well. Older patients, as patients get older, they have decreased muscular support in the pharynx area. They have a severe cervical arthritis that limits their neck extension, which by direct correlation suggests that opening or maintaining the airway would require neck repositioning and opening their mouth, and that could be a problem. They have an increased risk of aspiration. They have depressed lower esophageal sphincter tone. They have increased gastric emptying time. They have protected, the protective laryngeal reflexes are diminished, and of course they have a decreased number and activity of the respiratory cilia. They don't necessarily move the mucus out as much or as quickly. All of this makes a geriatric airway much more difficult to deal with. The pharyngeal muscle dilators, under normal circumstances, obstruction from the airway is prevented by 3 sets of dilator muscles, the tensor veli palatini, the genioglossus, and the hyoid muscles. Now, the tensor palatini prevents the airway obstruction by soft palate at the obstruction by the soft palate of the nasopharynx. The genioglossus pulls the tongue forward anteriorly to open the oropharynx. The hyoid muscles, as we know, pull the epiglottis forward and keeps it forward like that. In a healthy young person, the laryngopharyngeal area, these muscles prevent obstruction during sleep. Now, as patients age, the dilator muscles become less efficacious and there is a tendency for partial obstruction. The pulmonary morbidity associated with old age is also a consideration when you consider airway in the older patients. Ventilatory patterns are different, they're irregular, patients have apneic spells, and the anesthesia overall is very different for these patients. You need to bear in mind that their resting PaO2 is decreased, that resting ventilatory responses to both hypoxia and hypercarbia are not as robust, and there is an increased incidence for quick desaturation and quick movement to apnea. We'll talk about geriatric anesthesia here in this afternoon as well. The more of obesity that we'll talk about that'll come up, can't seem to, okay, there we go. Obesity is going to come up later as well. My patient yesterday in the operatory had a BMI of 57, and that is normal. We have now in the hospital setting, we have these things called hover mats, which is basically like a big hovercraft, which the patient lays on them before, they're laid on the bed before the patient lays on them, and then air mattress fills up, and then it rests on like this platform of air, and then you can easily push them like a pneumatic air vacuum. You push them onto the hospital bed, then you deflate it, the patient's settled on the hospital bed, no sweat. I can move a 600-pounder with my pinky finger these days. And so we'll talk about obesity here in a while. But it's important to consider some of these questionnaires. And stop bank score, for instance, is something that tells you, do you snore loudly? That's what the S is for. Are you tired? Has anyone observed you for stopping breathing during your sleep? This is a yes or no. Do you have high blood pressure? Are you being treated for it? What's your BMI? Is your BMI more than 35 kilograms per meter square? Is your age over 50? Is your neck circumference more than 16 inches? My shirt neck is going to 16, anything more than that. Now my stop bank score is going to change. What's your gender? Are you a dude or a dame? What's your high risk of obstructive sleep apnea is saying yes to 3 or more of these items. If you say no to 3 or more, then, or 3 or less, then you have a lower risk. So the sensitivity of this test is for mild sleep apnea versus severe sleep apnea is significant. So if somebody had severe sleep apnea, you are going to catch them in this testing. But if somebody's got mild sleep apnea, it's less likely you're going to catch them. The negative predictive value of this is about 90%. And as you remember, a negative predictive value tells you how likely it is that you actually don't have the disease. So it's about 90% here with this scoring. What happens if you're fat and obese? What happens to your respiratory anatomy? Of course, we know that there's a decreased range of motion. There's a decrease in your thyromental distance, less favorable Mallampati classification. Airway is more likely to collapse during anesthesia or leave alone just when you sleep. And there's a lot of lateral pharyngeal fat. My residents refer to it as a pharyngeal pannus. There's a lot of fat around the pharynx of bigger people. And just to do direct laryngoscopy requires a bigger, almost a flatter blade just to move this pannus all around, this pharyngeal pannus. So it's controversial actually if obesity is truly associated with increased intubation. There are studies that showed that difficulty in intubation is more common in obese patients compared to lean patients, and for only about 15%. So that doesn't necessarily mean that a bigger person is often more difficult to intubate if you prepare well for it. So for instance, if you actually place the patient in a reverse Trendelenburg position, keep the head elevated and in the laryngoscopy position, then it's easier to kind of put a tube through their neck. Now, in our offices with a dental chair in an operatory, this is a little bit easier if indeed we have to intubate somebody who's a larger body habitus. What one needs to realize, though, is that our play time when we have a bigger person is lower. So your oxygen saturation versus time to apnea is decreased significantly in an adult who is 120 kilograms as opposed to an adult who is 70 kilograms. So that is what we lose. So we have to quickly get back to ventilating the patient back up. The other anatomic alterations in the upper airway is also something to consider when you consider patients in the operating room setting or in the office setting. Those include obviously patients with atlantoaxial instability, such as in Down syndrome or rheumatoid arthritis or Chiari malformations. What about diabetes? Why should patients be evaluated for diabetes as it relates to intubation? I'll tell you what here in a second. Ankylosing spondylitis and spinal cord injuries are also something to consider when you have patients. So in Down syndrome, we talked about the atlantoaxial instability. They also have large tongues. In patients with diabetes, this is the prayer sign. The prayer sign is a simple clinical test that may be used to detect limited joint mobility in the hands. So a patient who has the Chiari arthropathy in their hands is unable to bring their fingers together because of the arthropathy. This arthropathy can also occur in the neck, and so they'll have some limitations in their neck movement when they have severely uncontrolled diabetes, and something that is often never described but is important and relevant in what we do and in case we have to get these patients intubated. The other issues with intubation anatomy is acromegaly, patients with excess growth hormone produced from the pituitary. If they have big tongues, big mouth, big mandible, prominent frontal sinuses, overgrowth of the soft tissues in the pharynx and larynx is common. Now, sometimes in your orthodontic surgery practice, you occasionally get a 35-year-old who grew after the fact that he was 30, and you suspected there was a pituitary adenoma, and indeed he did. And now that the pituitary adenoma is treated, you are called to treat his skeletal malformation and his malocclusion. When you consider a mandibular setback for those patients, be aware of the fact that they do have soft tissue growth in the pharynx and larynx, and often have obstructive sleep apnea, often have recurrent laryngeal nerve paralysis, and they can sometimes have limited range of motion of the TMJ just because of their growth in the mandibular condylar head itself. Arthritis is interesting because, in rheumatoid arthritis, synovitis in the TMJ can reduce mandibular motion. Still's disease or Still's disease of the juvenile rheumatoid arthritis can involve TMJ in a child, producing poor mandibular development and growth and can cause micrognathia. Cervical spine arthritis can limit neck range of motion, and when separation occurs, the odontoid process is kind of free to disarticulate to enter the foramen magnum and impinge on spinal cord and vertebral arteries. Often that is quite risky, and that can happen during intubation as well. And then, of course, there's cricoarytenoid arthritis, which could be a real problem. There are other disease processes that can alter upper airway management, and those could include muscular dystrophy, malignant hyperthermia, spinal cord injuries, and myasthenia gravis. And not to forget, there's often a burns patient somewhere on your radar that can come into your office for having the smallest of the thing, but can have significant limitation in their upper airway anatomy. So moving on to monitoring. So monitoring is often defined, and that is a continuous observation of data to evaluate physiologic function, especially when what we do alters physiologic function. It becomes even more important, and the rationale is to permit prompt recognition of things that are deviant from normal, a deprivation from normal, so you can quickly intervene and correct the problem. So corrective therapy can be implemented before, the fecal matter hits the rotating ventilator. talking. Yeah, hey. Yeah, yeah. I just no. No, I couldn't hear it. Yeah.
Check, check.
No, I couldn't. Ah, yeah, I can hear you. That worked. Yeah. Yeah. Let me just mute the phone. Hang on. Hello? Hello? Can you hear me? Yeah, I can hear you. I can hear you. Hello? 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 My mic is on. My mic is on. Hello? 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 My mic is on, and I can, like, on the screen it says I'm talking, you know, when I'm talking to the mic. Yeah. I can, yeah, I can hear that. Yeah, I can hear that. Yeah.
something.
Let me try talking. Hello? Hello? Can you hear me?
Can you hear us?
Yeah, I can hear you. So we're good? All right, good.
So we should be getting out the wire that's hooked up, so it should be perfect.
I see you and I hear you.
I don't know why we lost.
Hey, dude, we're going to start at 9:20, okay?
9:20? Okay.
9:20.
9:20 or 8:20?
9:20.
Okay, 1 hour?
9:20 our time, 8:20 your time.
8:20 your time.
Dude, I'm on Eastern time.
How are you?
he's Eastern.
Oh, okay.
Okay. Yeah, 9:20.
Okay, oh yeah, I didn't change my watch, that's all. All right, I'll see you guys back.
Dee, can you hear me?
Yes, I can.
Okay.
Hey, Joe, look in the camera. Here, I'm going to take a picture of you.
Can you see me?
I'll send it. Yeah.
Oh, okay.
Facebook Live.
All right, if everyone could take their seats, we're going to restart the meeting. Dr. Krishnan's going to get going here. Our next break will be at lunch at noon. Take it away, Dee.
All right. Sorry, I have no idea where I may have lost you, but I'm going to start with monitors because we have a lot more ground to cover before lunch. I do really like this format. I don't know how much involving it is for you, and I'm sure it's giving Joe a lot of heartburn, but the fact that I can actually get up and go use my own bathroom in between the talk is invaluable. So, all right, here we go. We'll get started, and hopefully everyone will settle down. Everyone going to settle down, you think? What monitors do you use, and what monitors should be used? So in my practice, I do tend to use respiratory monitors, as in pulse oximetry, ventilation, and good old observation of the chest rise, and the pretracheal stethoscope has always been there. And of course, now we have expanded into capnography. We've all spent all the money getting capnography in our offices. Cardiac has always been there. We always check blood pressure and ECG. And of course, the question then becomes, what about bispectral analyses? Is there any need for using this monitoring in the ambulatory care setting in our practices? The answer is truly no, because that's not necessarily how we measure the clinical effective sedation as opposed to the anesthesiologists do. We have our own ways of figuring it out in our settings, and the truth is that studies have been performed and it has not been proven to have any particular value at this time. But the role of respiratory monitoring is important. It's important to somehow figure out if we are getting and maintaining arterial oxygenation. We're not definitely trying to do any kind of arterial cannulation or doing transcutaneous oxygen monitoring, but simple oxygenation can be measured by measuring the oxyhemoglobin saturation, and that goes into adequacy of ventilation. We typically do this with pulse oximetry. And with pulse oximetry, you should realize that there's this light-emitting diode that is on the top of the finger and the nail, and that kind of gets the nail bed all saturated with that light. And that light has a photodetector on the bottom of it, and given that there's a constant hemoglobin concentration and the light intensity, the oxygen saturation of hemoglobin becomes the one factor, the logarithmic function of the absorption of light throughout the blood at the site of the pulse oximeter probe. So pulse oximetry has really gained a lot of momentum in current anesthesia provision because it's become a non-invasive method in which arterial oxygenation can be approximated. The functional oxygen saturation is determined by the absorption of the two different wavelengths during the pulsatile flow divided by the absorption of the non-pulsatile flow. And these ratios are put through a microprocessor, which is something we don't see, and then it comes out as a percentage value. And this value is an average percentage of hemoglobin that is combined with oxygen based on the last 3 to 6 seconds or so. The problem is that there's a delay in that, and there is limitations to pulse oximetry as well. So the continuous account of peripheral oxygen, arterial oxyhemoglobin saturation is what we get. It does somewhat catch the changes, although it's not necessarily rapid. The finger probe is so peripherally located and has a delayed response, sometimes even up to 30 seconds. It does not necessarily directly measure PaO2. And it definitely fails to detect hyperventilation in patients who are receiving supplemental oxygen, which can definitely muddy the waters. So in the limitation of oxygen in pulse oximetry, if you look at your oxygen dissociation curve, if you're providing extra oxygen to it, it's going to give you a false positive in any of this system. So the big limitation is that if you have carboxyhemoglobin toxicity that they show a classic cherry red appearance and exhibits all of that, the oxygen saturation is unreliably high in these patients and not necessarily true. In methemoglobinemia, it's going to hover around the 85%. In fingernail polish, especially green, blue, black colors, it could be a false reduction in SaO2 by 3%, 5%, or 6%. Cold extremity is a real problem. A lot of our patients can be a real hindrance in provision of this. Our nurses and assistants get all creative with that. They put a glove over it. They hold their own fingers over it. So obviously you're getting some amount of false negatives in that. Anemia can cause a saturation level that's different. Hypotension. But the saturation accuracy in hypotension of up to 30 millimeters of mercury is somewhat accurate, but the rest of it is not. So where does the probe function best? There is a delay between the alveolar oxygen delivery changes and when the SpO2 levels show that change. In general, the finger probes are slower, so 24, 35 seconds or so, as opposed to something that you can put on the ear probe. Ear probe shows the delay. It's more central in location, less time delay, and it's only about 10 seconds or so. If you put it on somebody's foot, for instance, that's going to show, or toe, for instance, the delay is going to be significantly more. So keep that in mind when you switch around your pulse oximetry. Sometimes for convenience, sometimes for reasons that are patient dependent, such as cold fingers and whatnot. So should we administer your supplemental oxygen? So if you remember that this is a rat fact that I'm not going to delve into too much, we all remember these from our physiology textbooks. The residual volume right here is what remains in the lungs after a big expiration, that expiratory reserve volume, the tidal volume, the inspiratory reserve volume. Hemoglobin may be completely saturated with oxygen before total pulmonary washout of nitrogen. Replacing all of the alveolar nitrogen with oxygen provides a depot of oxygen that might be necessary if the patient becomes apneic and mask ventilation or intubation proves difficult, which is why we want to give them the pre-oxygenation in any kind of scenario, including the fact that even if you're not using a mask to do that, you are going to use your nasal prongs before you start your sedation in the office. So during moderate or deep sedation, the adequacy of ventilation is important to be evaluated, and that should be done continuously. Now, for those of us that were trained before the advent of capnography and capnometers in our practices, we used to still use this gizmo. This is $40 on sedationresources.com or whatever, and this can be IV tubing, need not be anything fancy. I still use the old-fashioned one, although my residents have all started using the Bluetooth one. They find the tubing gets in the way of what they need to do, but I'm used to it. I know how to get around it. This thing costs about $500 or so if you have it. My nurses don't necessarily like the big speaker that sits in the office room because everyone hears the breathing, the coughing, the moaning afterwards that the patient makes, but they prefer that the doctor wears this. And so, of course, the torture then becomes ours. I still prefer the old-fashioned way. Of course, our practices have all absorbed in the practice of using capnogram and capnometry. So what is the difference between capnometry and capnography? Capnometry is actually a numerical measurement. So the numbers that you see there is your capnometer reading it. Capnography is the graphical display of the expired carbon dioxide over time. So that's more important and relevant to teach your assistants. So the number that you see is just as important as the graph. In the intubated patient where this technology was developed, you must understand capnography is built on infrared radiation techniques. So these techniques are based on the fact that carbon dioxide molecules can absorb infrared radiation at a very specific wavelength, and that can be measured. And so that's essentially what we are trying to do. It's an exponential relation of the carbon dioxide concentration percent in the breath sample. Now, in the intubated patient, that not only confirms intubation, but also detects disintubation or disconnects in the circuit. It does give us an appropriateness of minute ventilation and a numerical expired concentration of the carbon dioxide. All of that is great in the intubated patient. So what about those that are not intubated? The exponents, those that are opposed the fact that we need to embrace capnography in the non-intubated scenario that we are in, always fought against it, I think simply because of the reluctance to embrace change, primarily because you would think that in a non-intubated patients, none of the above is true. Yes, true. But having said that, having adapted to the technique very early on, I can endorse to you that it does measure the end-tidal CO2, provided you have the right kind of equipment catching the oral as well as the nasal expiration. It does definitely give you the graphic display of exhalation of carbon dioxide, and that pattern to me is much more important than the actual number itself. Now that pattern is seen by everyone in the room, so my anesthesia team knows what to catch, and we'll talk about what to catch. So how do you evaluate end-tidal CO2? It looks at ventilation. So it's an estimation of alveolar carbon dioxide and its partial pressures. So the alveolar and arterial carbon dioxide partial pressures differ by about maybe 2 to 3 milligrams of hemoglobin, assuming that ventilation and perfusion is usually matched physiologically. Carbon dioxide becomes easily diffusible across the endothelial alveolar membrane, and so there is a complete alveolar emptying of it during normal expiration. So if carbon dioxide being lower, increased dead space, for instance, in chronic lung disease, reactive airway disease, thromboembolism, somebody that is connected to the other end of the anesthesia machine and has a long circuitry, all of those things can be low, can cause a lower number of end-tidal CO2 reading. End-tidal CO2 does predict the outcome of resuscitation in CPR. So if you've recently taken your ACLS that tell you that levels less than 10 millimeters of mercury, levels less than 10 mm of hemoglobin after 20 minutes of standard ACLS CPR was 100% predictive of failure to resuscitate. So it needs to be above that 10. It does train us about the cardiac output like we talked about. It does give you an idea of metabolic activity, and like we talked about, the predicting outcome of resuscitation. So if I hook up one of my residents to a capnograph and have them take deep breaths in and out, this would be your normal capnographic waveform. The A to B, for instance, so let me go into the actual capnographic waveform there. There you go. The A to B, for instance, is the initial stage of exhalation in which the gas starts to be sampled in the dead space, and then it's free of any kind of carbon dioxide there. At point B, there's a mixing of the alveolar gas with the dead space gas, and the CO2 level shoots up abruptly. At C, and between C and D, the expiratory or the alveolar plateau is essentially alveolar gas only, and at point D is the maximum of the carbon dioxide and the best reflection of the alveolar carbon dioxide, and that is your end-tidal CO2. That is the number, the capnometry that we are reading. And of course, right from there, it plummets down. The patient inspires, the carbon dioxide goes away, and it returns to baseline CO2. So what can cause changes to this? So if I ask my resident to hold your breath, pretend like you are having partial airway obstruction. So then it can show changes in the graphical display as you see here. It's not that usual plateau that you saw in normal expiration and inspiration. It changes all around. If they hyperventilate and they go whoop, 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 and that means that they're not going to have that distance, C to D distance as much. It's going to be real conical. Airway leaks, increased dead space, and dislodgement of end-tidal CO2 will cause a flatlining of that. And low cardiac output can cause that, and so can pulmonary embolism. So in case of no end-tidal CO2, if something is disconnected or the patient's not breathing out at all, it becomes a flat line like this. What can cause an increase in end-tidal CO2? So somebody hyperventilating can cause an increase in CO2. A partial airway obstruction can cause the actual end-tidal CO2 to increase. Increased body temperature, such as in malignant hyperthermia. Increased metabolic activity, such as in malignant hyperthermia. All of those can cause that. So the shark fin waveform, which is basically phase 2 reflecting bronchopulmonary tree emptying, with or without prolonged expiratory phase, can be seen before an actual attack of a bronchospasm, for instance, or a significance. And this is your classic shark fin. If you hook this up, if you hook up an end-tidal CO2 monitor to a COPD patient, for instance, you're going to see this. This can be also seen in patients with severe asthma, restrictive lung diseases, or somebody going through allergic reaction having a severe bronchospasm. That's your classic shark fin. So in summary, this would be normal, this would be obstructed, this would be really bad obstruction, and this would be complete obstruction of somebody's airway. So if you can see this and something between here and here, so as we go through apnea and agitation in our patients that we sedate, these ninja fighters in our practices, they go through somewhere between here and here, and then of course there's complete obstruction as you try to swim them in some pool of propofol. So is this practical? What is its benefits? Can it really predict the changes that can be detected, that would be detected by pulse oximetry before those changes occur? The big difference is that pulse oximetry has all that delay, the 20, 30, 40-second delay when after the changes occurred before it shows up on a monitor, whereas the capnography, the graph itself, can predict the change almost immediately. So how can it be used? Is it safe and effective despite that open mouth and potential airway exhalation? What about the cost? The cost, of course, we have all gone ahead and bought the stuff, and we cribbed about it when it was $1,500 to $30,000. We have to upgrade all the equipment in our offices. But I tell you what, the cost of such things is the cost of safety. If you have one more tool that you can go ahead and protect your patients from the peril of your own inconveniences, I tell you, it is the cost of safety you're paying for. And if you haven't adapted this yet, not only are you behind the curve with what is current parameter of care, but also you're probably not necessarily doing the right thing. So if you have used a laryngoscope any time in the last 30 years, you probably remember the Cormack-Lehan laryngoscopy grades. If you don't remember it, grade 1 is your full view of the glottis, grade 2 is your partial view of the glottis, and only epiglottis is seen in grade 3, and nothing is seen in grade 4, and it is going to be, I'm going to try putting that tube in, hopefully it'll go not into the goose, but into the gander. So mallampati grade cannot necessarily be correlated, but there are studies where people have looked at correlating what is a MP1 or a mallampati 1 to a laryngoscopic view, and there is some proof that about 90% of the time this and this is true, and this is true, but this and this and this and this don't necessarily always correlate. Now ASA comes out with their difficult airway algorithms, and they update it here and there every few years. Well, what happens is that when you have an anesthesiologist that is the sole provider of anesthesia without a surgeon in the room, say for instance the surgeon happens to be a podiatrist or an orthopod who has never done a surgical airway, and there is nobody else in the area that can do a surgical airway, you're going from here to here is really difficult in all of this. Oftentimes, if you recognized with proper preparation, you can go ahead and do whatever it takes to intubate that patient. Oftentimes, patients are awake. With new drugs such as Presidex, for instance, awake intubation has become a walk in the park for a well-trained anesthesiologist, between keeping the patient sedated but not losing their respiratory drive to better fiber optic intubation technique and practice and simulation. All of this can get well. But if it's under-recognized or poorly recognized and you were not prepared at all, it quickly moves down to a surgical airway or anesthesia with mask ventilation. This goes back to what we were talking about. If you cannot ventilate, don't attempt to intubate, and then don't attempt to sedate. because difficulty in ventilation is where it all comes down to. If you are in a situation where you cannot get a surgical airway and you cannot get a mask ventilation on the patient, you're doomed for failure at that point. That patient's probably going to die in your offices. And so while we are quick to move on to doing a cricothyroidotomy in our practices, if this does happen, think of the last time you had to do one or the last time you did one. In my own instance, I can tell you that I can probably struggle through one. I've done slash trachs in our practices on the airway and on an airway in a patient on the surgical ward, but that was not the best experience. And I can frankly tell you, candidly, I just got lucky. Otherwise, that patient would have died. And so it's not always easy. And the one that becomes a difficult airway, that becomes difficult to mask ventilate, will be the hardest neck to get a surgical airway in. And keep that in mind as we set up our airway. So in our practices, instead of running through straight to the number 15 blade to make an incision on somebody's neck, we probably have to think about airway setup in each operatory that includes your drugs, airway adjuncts, your suction equipment, and your peripheral oxygenation equipment. In your crash carts, if you haven't looked at your own office crash carts in a while, I think you should probably look at it every week, if not every day. And you should not rely on somebody else to do that for you. If you are the sole practitioner that is in charge of everything that would go wrong in your practice and get no credit for anything that goes well in your practice, then you should probably stock up your crash cart yourself. Should be kept in a central area, should be near an oxygen tank that is always checked for fullness. It should have a regulator, and you should know how to put that regulator on. Simplest task that we struggle with is to put the little clutch thing, the little spanner on the oxygen tank and turn it on. So a lot of people don't know which end of it goes on, and a lot of people can put it off the wrong end and turn the whole thing off instead of turning it on. Using the bag valve, bag valve mask ventilation equipment, and teaching your assistants to hold a proper seal while you are getting a proper IV or preparing to intubate. That's important. Having the appropriate airway adjuncts, having the appropriate laryngoscope. There's no right or wrong laryngoscope. Maybe you're a Miller kind of guy. Maybe you're a Mac kind of guy. Whatever works for you, make sure it has batteries in it. In the hospitals now, we have these disposable laryngoscope handles and blades. The entire thing is throwaway. It's got an LED light at the tip of it as opposed to it being something that is transmitted like we used to have back in the day. Have a stylet ready. Keep your LMA or your iGel or your choice of supraglottic airway ready, and make sure that your suction as well as your backup suction works. In the snowstorm the last winter, I believe, this winter we haven't had any significant snow anyway. The power went out while we were doing a sedation in our practice, and we ended up having to look hard to find the backup suction. And the new girl that we had just hired, of course, didn't know where anything was or how to turn anything on. And because the boss is the boss doesn't learn how to turn trivial things like turning the suction on the backup suction. I had no clue how to do it either. And so there was a little bit of sphincter tightening moments for us in our practice. So simple things like preparing yourself with the equipment you have would be good. In patients with expected grade 3 and 4 views, having an airway bougie or an exchange catheter, or at least keeping a Cook airway exchange catheter on your crash cart is usually useful. The real question comes down to, if you do need to go in to do a surgical airway, when was the last time you did it like we talked about, and can you perform it? Remember the landmarks. You got to feel the Adam's apple, come down and feel for the soft spot between the thyroid membrane, the thyroid cartilage and the cricoid cartilage. Make a vertical incision. Don't go with how you used to do your tracheostomy incisions and go horizontal. You're going to get into the anterior neck vessels there. It's going to be a bloody mess before you try to find the cricoid area. And of course, if you can shove down an endotracheal tube, a pediatric tube. If you have an emergency cricothyroid, thyroidotomy kit in your office, that's good, but what's the expiry date on these? Not that any of the things in there will expire and turn into dust, but that the sterility of the package is going to get worse over time, and so may end up ordering new ones. But basic equipment is all you need. You don't need anything fancy. If you can get a cricoid hook as a part of your armamentarium, that's usually useful. But if you have a SIN retractor on your biopsy tray, that'll work just as well. Your nasopharyngeal airways are your friends, especially in obese patients that you're trying to do sedation in. It's not uncommon for me to walk into a resident doing sedation in our practice to find both the nostrils filled in with nasopharyngeal airways. Remember, it's up the nose with a rubber hose, so it doesn't go up the nose, it goes along the palate, and we know this from our anatomy, we know this from our anesthesia experience, actually much more than an anesthesia student does. And we often end up teaching them how to do these, including nasotracheal intubations in the operatory, as a lot of us have experienced in our practices. The oropharyngeal airway should be taped onto your IV pole. It shouldn't be anywhere else. It should be there for every case, and a couple of the sizes should be there depending on your average patient. If you are in a cush private practice that does nothing but 17-year-old third molars, you probably should keep the medium size for the banker's daughter when you need it. If you're in my practice and you have more and more of bigger and bigger people coming in to have all of their teeth taken out, you want the bigger sizes and the jumbo size of the oropharyngeal airway taped to your IV pole. Do measure it. This is fairly accurate and reproducible. If the airway is too large, actually placing these are a hindrance. And if it's too small, it's often ineffective. So insert it, I like to insert it backwards and turn around at the palate, seat the airway with a jaw thrust maneuver, bring the tongue into the curve of the airway and place it properly. So if you do have to get a laryngoscope out, remember that you need to optimize your visualization, minimize the angle between the oral axis, the pharyngeal axis, and the laryngeal axis. We will skip through some of these basic stuff and move right on to what I feel is important to address: supraglottic airway devices. I don't necessarily subscribe to the fact that those of us that haven't done intubations in a long time cannot intubate anymore. That's not true, and it's been scientifically proven. Actually, Jeff Bennett and I did a study. We took around an airway mannequin to ADSA meetings and AMOS meetings and randomly asked people to intubate the mannequin. We measured the timing that they took between the first view of the airway and first inserting the laryngoscope blade in and placing an airway and confirming it with a CO2 device. And interestingly, and the only variable was the fact that they'd been out of training 30 years or 3 years or currently in training, never did anesthesia training, whatever it might be. And we found that there was no significant difference between people who had not intubated in 30 years and the current resident who is on anesthesia rotation. Just about anyone who had done a few number of intubations and had trained in doing an intubation could intubate a mannequin without any problems. That doesn't mean they can intubate in real life, but at least the study looked at that one mannequin. And if you've tried intubating these ACLS mannequins, they are painful. They are difficult to intubate, so there's no way that we are getting a lot of them intubated properly. But we found that actually people could intubate, and we should be proud as a society, as a population at large, that we are fairly well trained. And it's kind of like bicycling, I guess. Even if you haven't ridden a cycle in a while, you can always get back on it and find your balance after staggering around a little bit. Having said that, the chances of having a disaster from attempting an intubation in a difficult airway is high. And if that be the case, we should probably not reach for an endotracheal intubation tray right when we have an airway going south. Your better bet is to get a supraglottic airway device. These are minimally invasive devices. These are inflatable mask fitted through a tube, and it occupies the space above the pharynx in the hypopharyngeal area, and it forms a seal above the glottis. It should be your go-to rescue airway. Now notice that I use the term supraglottic airway device as opposed to saying LMA, because an LMA is actually a patented a trade name. And this particular supraglottic device is the first one that was a supraglottic device. Since then, many other LMA designs have come out. So while that is your classic LMA or your LMA unique, there is the LMA Fast Track and multiple other modifications of the LMA, like the Pro Seal, for instance, and the LMA Supreme, the LMA C-Track, which actually has a screen attached to it. Now, the generation of residents that we are training now all like screens. They're screenagers. And the screenagers like to look at things away from where they're actually looking. They have a higher level of hand-eye coordination, which makes them better arthroscopists and definitely better endoscopic surgeons. So they do like these devices. So all these video devices are gaining a lot of popularity among the younger surgeon, if you would. I do use the LMA flexible quite a bit. I use this for routine third molar surgery for patients who are heavier set with large tongues. I place this, protect the airway, hook it up, and I move the tube left and right as I tackle these tumors behind the second molars and remove them, and then I take these out. The patient's usually sedated intravenously and does not need to be hooked up to a positive pressure ventilation system or anything like that. You know, hook it up to your routine anesthesia machine and have them breathe through that. But it just simply protects the airway, make sure that things don't go down from the mouth on a big tongue and gets out of control. Now, you don't need to muscle relax patients for this. Laryngoscopy is certainly circumvented. Hemodynamic changes during insertion is minimized because it's not invasive at all. What is contraindicated or relative contraindication are those patients who have not fasted. So the concern being, since this sits right above the glottic opening, if in case they do throw up, then it becomes an issue where they don't necessarily, they can't necessarily they can aspirate and you don't necessarily catch it while they're aspirating. Patients who are morbidly obese, it's probably not a great idea to use this, again, because of their higher rate of aspiration and the fact that their clearance in their stomach has been delayed. Patients with hiatal hernia and GERD, same reasons why you shouldn't do that. So what are some of the complications of placing an LMA? Patients that cough quite a bit can have an issue with that. They can go into a laryngospasm if they cough a lot and bring up some secretions, and that tickles the airway quickly. Labored breathing can be a problem. The incidence of regurgitation from an LMA is reported to be probably around 25% or so. While you place the airway, you can have a complete airway obstruction when you place an LMA, for instance, if you don't place it properly, because the tip of the epiglottis can be folded into the vocal cord itself. That can cause some coughing and obstruction and subsequently laryngospasms. The incidence of sore throat is lower than in an actual endotracheal intubation. It's 7 to 12% or so. And of course, there's dysarthria if you are too close to the vocal cords, for instance. The LMA cuff itself is permeable to nitrous oxide and carbon dioxide, which can result, as you're placing it, it can result in an increased intra-cuff pressure, especially if you're doing a long case with it. And elevated intra-cuff pressure can increase the incidence of postoperative sore throat or dysarthria, for instance. Some people can even get edema of the epiglottis, the uvula, and the posterior pharyngeal wall from all of this. There have been reports of hypoglossal nerve injuries from LMA placements or supraglottic airway placements. I think that's particularly true because the hypoglossal nerve is vulnerable to the injury, where the nerve kind of loops anteriorly and gets around the hyoid bone area, and that's where this thing kind of sits and puts some pressure on, and that can cause a problem for some patients postoperatively. Aspiration during elective patients undergoing complete general anesthesia with an LMA, about 3 in about 10,000 patients. That's not necessarily a big deal. But if patient does cough and throw up, then pulmonary aspiration is a real problem because LMA does not protect it. In our institution, we use this particular product. It's called an eye gel. It doesn't require any kind of air insufflation, for instance. It works as an integrated bite block. Gastric suction is possible through a little vent on the side. And as it's inserted with the patient's own body temperature, it kind of molds itself to the anatomy and kind of provides a really good seal around there. There is good evidence to suggest that this causes less laryngeal trauma. It's so much more easier to insert because there's not like a floppy cuff at the end of it. I don't have to worry about and remember if I need to truly inflate it before I place it or I need to place it deflated. Now, depending on the anesthesiologist who taught you how to do it, you could do it either way. It does maximize airway pressures, and in all our crash carts, this particular product is kept. It costs about $35 to $40, and you can't buy it as one piece. It actually comes as 3 sizes, and you cannot get each piece is not sold separately like they write at Costco and Sam's. You have to buy the whole pack. So these devices get in there, and there are other devices like the King Airway, for instance, or the LMA, the iGel. The Combi Tube is something that ACLS still teaches, and it shows almost a fail-safe method to kind of place an airway, especially in the theater, for instance. So if you're an EMS, all the EMSs carry these Combi tubes with them in the Ohio area. It's kind of difficult not to get the patient intubated by design of these instruments. There's also multiple other kinds of supraglottic airway devices, and these are listed here. They are the Cobra, the Cobra perilaryngeal airway, the cuffed oropharyngeal airway, and video laryngoscopy is interesting. There is some talk when we were making the parameters of care whether we should start asking most of the AMS members or oral maxillofacial surgeons in practice to start considering getting these into our practices. I don't have an opinion on this because I do use quite a bit of the King Airway, for instance, and the glide scope. The glide scope is interesting. It's very expensive these days. It's about 15 grand or so. Contrary to most things getting cheaper and cheaper, the glide scopes got more expensive. I don't know what the dealio is, but anyway, it is not something that's practical for us to have in our offices. But what is practical are these other devices, such as the McGrath Airway or the King Airway or the Vivid Track. The Vivid Track is important. This little device here is only about $15, $20 or so. It hooks up with a USB port to the laptop or the computer that's sitting in your practice, or to an iPad, and you can see what you're doing with video laryngoscopy. A lot of people struggle with the video laryngoscopy just because of the hand-eye coordination or discoordination, and would much prefer a direct laryngoscopy any day over a video laryngoscopy. But there are some definite pluses of using a glide scope, for instance, in patients with decreased mouth opening. I'll skip through some of this stuff here to get to the medical management. All right, here we are. So we're going to hit 3 or 4 systems today, and like I said, my intent is not to bore you with the rat facts of cardiac disease and understanding what the cardiac patient is, but it's often the last time we read these things, and if you don't keep in touch with and read the New England Journal of Medicine, for instance, on a routine basis, a lot of the basic changes in practice go unnoticed, and all of a sudden your patients in your practice have a new drug that they're taking, and the next guy has the same drug, and you're wondering, oh, is this the new drug in fashion for the cardiologist these days on patients who have had a recent MI, for instance? Now, we're not cardiologists, so the problem is that we don't have to understand cardiology to the level of a cardiologist, but we need to make sure that we risk stratify our patients to make sure we don't do any harm. So here we go. Which of the following functional states is considered a threshold for elevated perioperative risk? So if somebody can do some self-care, washing, eating, etc., has no problems walking up flight of stairs, walking 1 mile in exactly 16 minutes, no less, no more, jogging 1 mile in exactly 10 minutes, no less, no more. And if you read through those, the true answer there is walking up 1 flight of stairs, and that is considered the cardiac functional status for looking at elevated perioperative risk. So we are not a cardiologist, but as a surgeon and an anesthesia provider, you must be familiar with concepts of cardiac risk, commonly used risk stratification methods, and commonly used risk stratification indices. And that's important. So in 2014, the ACC and the AHA came up with guidelines on perioperative cardiovascular evaluation. And so these were based on 5 factors. Now, your H&P of the patient, patient-specific clinical variables, functional capacity or METs or metabolic equivalents, and the type of surgery the patient's going to have done, and resting ECG. There's a percentage of risk that could be calculated of cardiac death or non-fatal MI if you consider these 5 factors. Now, a lot of these we do, whether or not we realize that those are the cardiac risk stratification factors as prescribed by the AHA or not. We do them. We take blood pressure, not necessarily in both arms. We do our physical exam. We can catch a carotid or a jugular pulsation or a bruit if we see it. We certainly listen to their heart and lungs, so auscultation can catch murmurs. We can tell a protuberant abdomen from a distended abdomen, hopefully, and we definitely should check for peripheral edema in extremities, or at least ask about it in our questionnaire. Now, the patient's specific clinical variables are separated into major or minor predictors or moderate predictors for perioperative cardiac conditions or problems. The major predictors can delay or cancel your non-emergent procedure. So you've done your due diligence, you found that the 57-year-old woman who's in your office for full mouth extraction needs to go to the operating room because she has on and off chest pain and she has peripheral edema. And when you listen to her, you can't really hear her heart and you wonder if she has some cardiomegaly. And so what you're suspecting is that you need to go to the operating room. If you did go to the operating room but your anesthesiologist didn't do a thorough enough workup for this patient, there's a good chance that you will either delay or cancel that procedure because that could lead to unstable or severe angina, or they may have had a recent MI that may have gone unnoticed, or have a severe dysrhythmia or severe valvular disease that may have gone unnoticed as well. So in patient-specific clinical variables, the moderate predictors that often require a consultation and often require pre-surgical workup are patients with significant history of coronary vascular disease, have stable angina, have non-emergent hypertension, stable dysrhythmia, non-ischemic MI about a month before, and have had their plumbing replaced with new stents, and they're currently on some kind of antiplatelet therapy, compensated heart failure or history of heart failure, diabetes in addition to the cardiovascular problems, and renal insufficiency in addition to the cardiovascular problems. So based on metabolic equivalence, so if somebody is somebody who plays squash every day, for instance, that's somebody who has a great functional capacity. But if somebody cannot walk a flight of stairs, then they have poor metabolic equivalence, and they're not necessarily somebody who has a good cardiac functional capacity. So decreased cardiovascular function and perioperative morbidity increases if there is 4 or more METs without symptoms in patients. If not, further workup might be necessary. Cardiology consult is necessary. Something more than okay to proceed with surgery on a prescription sheet is what you're looking for. You're looking for a thorough cardiovascular functional eval with reports of their recent stress EKG, echo, and nuclear scanning is what you want back before you consider that patient for surgery in your office. So the example for METs, like we talked about, playing squash is excellent, whereas, if you're like me and spend a lot of time at the desk, you're not necessarily a good candidate. 1 MET is equal to the oxygen consumption of a 70-kilo 40-year-old adult at rest. Now, there are very few 70-kilo 40-year-old adults left in the world these days. So factor 4 is the type of surgery and the cardiac risk that you should consider. And that's important because what we do is not necessarily considered, what we do is not necessarily considered high-risk surgery. Major vascular peripheral arterial surgery is what high-risk surgery is. Intermediate surgery, for instance, is, major head and neck surgery. So big cancer surgery, big fracture repair, orthognathic surgery could go into this. But most things that we do is considered low risk, such as ambulatory procedures that we can pull off, cataract surgery, endoscopy, breast surgery, etc., etc. So then comes the fifth factor, which is the resting 12-lead EKG. When should you get that? When do you need to get that? According to 2014 AHA guideline, if you have one major or moderate predictor, you should get it. Any high risk or intermediate surgery, you should get it. If, according to this, the ASA1 Fatahi class 2, 3, 4 surgery, so blood loss greater than 500 cc's or so, women greater than 40 years of age and everyone greater than 60 years of age should get a 12-lead EKG. These do correlate with what we discussed earlier, University of Nebraska's pre-anesthesia protocol. There are good studies that show that there is an increased perioperative cardiac complication with Q waves and significant ST elevation, depression, etc., or other dysrhythmias when you don't necessarily work this up, and that changes on a resting 12-lead EKG can be the same and can be predictors of further dysrhythmia intraoperatively. So if you look at a revised cardiac risk index, or the RCRI, which is also an important thing that anesthesiologists use quite a bit, 6 independent risk factors. They are predictive of major perioperative cardiac complications. 1 is the high-risk surgery itself, 2 is current ischemic heart disease, 3 is current cerebrovascular disease, 4 is diabetes treatment with insulin, 5 is heart failure, and 6 is preoperative serum creatinine greater than 2. So this is quite system-based. These are considered revised, and they're considered independent predictive risk factors. And some value for that, again, major surgery indications, not something that we would do. So according to that, if you consider those risk factors, death or non-fatal MI and survived cardiac arrest for non-cardiac surgery, nobody had, if somebody had 0 risk factors, then that correlated to 0 risk. 1 risk factor, 1 risk. 2 risk factors, 2, 2.5 risk. Greater than 3 risk factors, 5% risk. Increased values later on. There's ongoing studies. They're trying to actually, if you go to the Society on Ambulatory Anesthesia, they now have an app for risk calculation in surgery based on this RCRI criteria. But it's, again, I'm not sure we can quite extrapolate this into our office-based practice quite yet. There are other risk index scales. You probably heard about the Goldman Index, the Fleischer-Eagle Index, but the RCRI seems to be the most commonly used one these days. So how do you take away such information and make it practical to your practice? So office-based surgeries are low risk. Cardiovascular morbidity associated with them is less than 1%. Major oral maxillofacial surgery, or OR-based surgery, is classified still as low to intermediate risk. Nothing we do is, intravascular. Nothing we do is intracranial. Nothing we do is manipulating the cardiovascular physiology significantly. We can, if you're somebody that treats a lot of vascular lesions, for instance, have tremendous blood loss to your acumen, then this could be considered major surgery. That focused physical exam and good exercise tolerance screening tool, specifically looking at metabolic equivalents. Can they dress themselves? Can they walk a flight of stairs? Can they go around a street without any problems, a block without any problems? Those are the kind of things that help you screen through. ECG and or cardiology consults, depending on the extent of surgery, age, gender, and your focused H&P. So we'll delve a little bit into cardiovascular diseases and speak a bit about some hypertension, atherosclerotic disease, dysrhythmias, valvular disease, and cardiomyopathy. So if you're a 45-year-old diabetic on daily metformin, at which blood pressure level would you defer extraction of mildly symptomatic number 30 under local anesthesia? 1, 160 over 100, 2, 170 over 100, 3, 180 over 110, and D, 190 over 120. Now I took this out of the Amos Office Anesthesia eval manual, and I really want to see who would take a patient. I can actually see you guys, so I'm going to see if I can get to see you. There you are. So how many people, raise your hands for me, how many people would take a tooth out, number 30 under local anesthesia, 45-year-old diabetic male on metformin, blood pressure of 190 over 110? Would you? No. 180 over 110? No. 170 over 100? Yeah, I would too. 160 over 100? I wouldn't mind. Well, you know, probably okay to get 180 over 110 too. I remember a rule that my chief resident taught me when I was an intern, that if you really think that somebody's blood pressure is, if the sum total of their diastolic and systolic blood pressure is greater than 300, don't do a thing to them. Get them out of your office and to the ER, regardless of whether it's an emergency or an urgency, as in, you know, relates to symptoms or asymptomatic. I still keep that in the back of my mind. It's got no bearing whatsoever on evidence-based medicine, but think about it as a general guideline. If their diastolic and systolic add up to 300 or more, not a good patient to be in your office at that point. So hypertension, an asymptomatic blood pressure of 145 over 95 has a hypertension classification of A, prehypertension, stage 1, stage 2, or urgent hypertension. Now, stage 1, according to, you know, JNC guidelines 7, but JNC guidelines 8 have now de-emphasized any kind of classification of hypertension. So essentially there are basic types of hypertension, but that has gone away from class 1 through class 4 to essential hypertension, and that's a multifactorial process. So if you are an African American male with a family history, who is obese, who is older, has had KFC for the last 5 days in a row, and has metabolic syndrome, they probably will have some hypertension. But then there is secondary hypertension as well, and secondary hypertension is either secondary to drugs such as oral contraceptives, chronic NSAID use, other predisposing factors like Cushingoid disease, aortic coarctation, hyperaldosteronism, renovascular disease, obstructive sleep apnea, endocrine disorders, etc., etc. And then there is the isolated systolic hypertension. Older adults, due to aortic or valvular calcifications, can have systolic hypertension of greater than 140, and diastolic remains under 90. Now, rat fact. Your renin-angiotensin-aldosterone system, only thing you need to remember from this is that this is a multifactorial, multi-organ related system. So between the kidney, the lungs, the liver, and the pituitary, and the secretor receptors within the arterioles, as well as within the collecting duct of the kidney, all of this goes into regulating the hypertension and keeping it alive for us. Problem with hypertension is the fact that it can cause an MI, it can cause claudication or CVA from atherosclerotic disease, it can cause renal failure from attacking the kidney, and that can be additive with especially diabetic patients. Retinopathy can occur, and eventually heart failure can occur. So remember the old classification of emergent hypertension and urgent hypertension. So urgent hypertension is somebody who has a hypertension, increased blood pressure in your office, but does not necessarily have any symptoms. But emergent hypertension is when one of these target organs are showing some symptoms. So if they are having a terrible headache, they probably have some cerebrovascular thing going on, or retinopathy going on. They're having visual changes. They have chest pain. They have some MI going on or CVA going on. If they could have bleeding in their while they're urinating, or having kidney pain, that could relate to renal failure or impending renal failure. That would classify it as an emergent hypertension as opposed to an urgent hypertension. So we're going to skip over some of these medications. Nothing new to present here. ACE inhibitors, renin blockers, thiazide diuretics, other diuretics. Aldosterone, remember those residents in the audience, when you take your boards and when you take your oral boards, these things are important to remember. Some rat facts are important in the oral boards, so keep that in mind. Drugs used in the treatment of essential hypertension, calcium channel blockers, beta blockers. Now, if you don't have beta blockers in your office, you should probably get some. It's important to have that around, especially for managing intraoperative hypertension in your sedated patients. Alpha-1 blockers, not very good for monotherapy, and alpha-2 blockers. It's a lot more. Clonidine as an alpha-2 agonist, for instance, clonidine as a drug has come to the forefront for management of multiple diseases, not necessarily of hypertension. It is also being used as a as an oral sedative for sedation in practices as well, especially in patients with ADHD, for instance. The JNC classification, kind of important to remember this, but this is again a rat fact: normal, pre-hypertension, stage 1, stage 2, and urgent hypertension. There's the emergent hypertension, like we talked about, with signs and symptoms of end-stage damage that is being presented. That's important to realize that since the JNC treatment guidelines, some things have changed. So they used to treat they used to initiate treatment when systolic blood pressure was greater than 140 or diastolic was greater than 90, or if in the presence of diabetes or chronic kidney disease, it used to be even lower. And the first line treatment was a thiazide diuretic, considered an ACE inhibitor, a calcium channel blocker, etc., etc. And just when you thought that you got the drug combinations all good and ready to go and understood JNC treatment guidelines, they came up with JNC 8. Now, there is no change in the actual classification, but there is less stress on the actual classification. So this is now consensus based on multiple meta-analyses. So there is a change in the way that we approach our understanding of hypertension is what you need to take away from this. They do set targets of threshold systemic and diastolic blood pressures above which are recommended for treatment. Now, that's based on age, differs in the presence of chronic kidney disease and diabetes. Specific drug treatment suggestions differ based on race also, as well as in the presence of other comorbid conditions. JNC recommendations now target age, that's a big deal, and patients with diabetes and race as well. So this is how it's being treated. In the general non-black population, thiazides, calcium channel blockers, ACE inhibitors, etc. are initial therapy, and then in the African American population or African population, thiazides are initially provided. Now, if you are Indian like me, you're kind of stuck in the middle. We don't quite understand how this works in other races yet, and so we'll probably wait till JNC 9 or 12 or something until we get our hypertension treated. So the drug summary for JNC 8, if not goal within a month, increase initial dose or add an additional drug. That's important. If still not to goal, then there's a third drug. So if you see a patient in your office with 3 medications that they are on for simple hypertension, and they've had that come on in the last few months, then there could be something else happening. And their recommendation is go to a hypertension specialist. What essentially that means is they need further workup. And that's important because there might be other systems being intercepted at that point. They're not simply having hypertension. They are a little bit more complex than that. Severe hypertension has gotten a little bit more attention in patients that are having perioperative management. In patients that show up with severe hypertension, that could be a response if you actually treat it immediately. So without comorbidities, the number seems really high, but if you think about the office anesthesia manual and what currently our practice is, we don't necessarily treat hypertension unless it is coming along with our sedation. So the consensus is generally continue all the hypertension medications if well controlled. Some concerns with the ACE inhibitors or the renal hyperperfusion that can be affected. Some diuretics are of concern, especially if they're not on a potassium-sparing diuretic, and the volume status on diuretics is to be considered when you consider sedating somebody who is on hypertension medications. Do not stop beta blockers or alpha-2 agonists. They usually cause significant rebound in the hypertension and increase sympathetic tone in patients. In the OR or the hospital settings, things are a little different because you could potentially use invasive hemodynamic monitoring like an arterial line. The real key is to figure out why they have a hypertensive emergency. Why are they in pain? Are they anxious about the appointment, or is it an endocrine issue? Beta blockers could be useful, and vasodilators could be useful, but you don't want to over-treat it and send the patient home, especially in our setting. If somebody comes in, you're doing a sedation and their blood pressure is up to 210 by 110, don't want to pump them up with labetalol or give them clonidine and send them home and expect it to maintain or balance out later. All you know is it's going to cause a delayed acute reduction, and that can be a real problem for these patients. It could be the concept of de novo, or the first time they show up with hypertension is in your office. The emergent hypertension is when, like we talked about, high blood pressure with end-organ damage. If that does happen, that's an emergency room visit right away. Same as malignant hypertension. That is also a trip to the emergency room. So inpatients, that residents that are in the audience, if you have a call from the nurse, patient on 5 East is having increased blood pressure, your attending has done a TMJ replacement surgery, and patient's otherwise not had any kind of hypertension according to history. Now they have high blood pressure. First thing to do is go and check the patient out. They're an older patient. Can you decrease the blood pressure without causing any kind of encephalopathies, or causing, or is the high blood pressure okay at this point? Are we in concern for an ischemic CVA? You don't want to decrease the blood pressure immediately, and that can cause some labile results. The IV regimen is typically utilized in malignant hypertension, and PO regimen can also be managed, but that usually takes several days. What about in the procedure, in the office procedure with hypertension? The most important thing is to establish baseline. You need to know where they were before they started, where were they at the time of the consult. Establish that cause. Maybe it's the fact that your block is not working, and that is oftentimes the biggest cause for causing pain. Just dialing up the propofol is not going to really help with managing that sedation unless you control the pain. Maybe they haven't had enough anesthesia. They have severe anxiety associated with this visit, and that's something you can titrate. Hyper or hypercarbia and hypoxia can also manifest as hypertension. Intravascular deposition of vasoconstrictors. You are going to do an all-on-4 case, or in my case, it's none-on-3. And those cases, you got a lot of vasoconstrictor in circulation, and you happen to pump a couple more up into somebody's blood vessels. Delirium, fluid overload, bladder distension, long case, pre-op stimulant use, methamphetamine, cocaine, marijuana use, all of these can cause some significant intraoperative procedural hypertension. Does that need to be treated is really the case. Is this something that we see? Are we going to let it go? Of course, it's going to be a bloody field. Other than that, so in the elderly especially, don't dial it down so much. The rule of thumb is to consider acute medication therapy if the systolic is higher than 200, diastolic is higher than 100, and once all the other causes are ruled out. So if it is an empty bladder, emptying the bladder, maybe the patient just needs to wake up and go and pee. Maybe your block just needs to work better. Maybe slow down a little bit or give them a little bit more anesthetic. Acute office-based therapies include beta blockade, alpha blockade, and peripheral vasodilation. And I have listed in my handouts the details of all these drugs, which I don't think we need to discuss in detail as a part of the lecture. But this is for you, and it's over there. So what about intra-op and post-op hypotension? That is sometimes a bigger issue in a lot of our patients than hypertension. So if you identify the cause of that, maybe they are getting syncopal, maybe it's a vasovagal issue, maybe they are hypovolemic, they were fasting all night, and your appointment happens to be at 3 o'clock in the afternoon, and now you're going to sedate them, they're going to be a little hypoglycemic in addition to be hypovolemic. So all of that can dial into the hypotension that they're exhibiting now. IV anesthetics, and overdose of them, if you miscalculated the fact that the puny little child that you're going to expose and bond a canine on cannot necessarily be sedated quickly just because your benzos and your opioids didn't work. Don't overdose them with propofol, because propofol and barbiturates can actually cause significant drop in blood pressure, as you know. Orthostasis can be an issue. Now, in the geriatric population, they have an increased anesthetic sensitivity and a lower reserve, and so more than likely the touch of midazolam that you give is probably all you need to sedate the patient for the entire procedure. Now, bear in mind that a sudden drop in blood pressure could also suggest acute allergic reactions or acute hypoadrenalism, and all of those have to be on your differential if patients are not necessarily responding to treatment. And what could that treatment be? Treatment of the intra-op hypotension, stop the procedure, assess your ventilation and circulation, check your blood pressure again. Maybe it's just positional. Place the patient in a Trendelenburg position, stimulate the patient a little bit, consider reversing your anesthetic agent. If you just gave them 15 of midazolam, maybe they didn't need that much. Give them a bolus, turn open that IV. If you don't have a response to that, consider the other reactions. Maybe it's an allergic reaction or a hypoadrenalism that is the issue. What if the patient also happens to be bradycardic in your office? You need to rule out syncope. You need to rule out MI. You try to give them some atropine. Maybe you repeat that every couple of minutes or so, see how they do. Ephedrine, perhaps? I don't necessarily want to always reach out for ephedrine. This is not a drug I use routinely. I always have to look up the dose and how often to give and things like that. It's contraindicated if the patient's especially on a MAO inhibitor. Now, if you have patients on a MAO inhibitor, you should be careful about using any kind of drug for that matter, because if you've taken any kind of multiple choice questions and one of the responses on that is a MAO inhibitor, that usually is the answer, which means it's usually a bad thing to be on, and that necessarily means that you don't want to give it to patients either, or give patients with that either. So consider the causes. That's the biggest thing. Why is the patient hypotensive? And then, of course, sympthomimetics. Phenylephrines right around the corner with us whenever we do general anesthetics in the office, so that can potentially be used to treat the hypotension. And it's that dialing game. I wish we had a dial. You could dial up the blood pressure a little bit, dial up the phenylephrine a little bit, this and that. That's how we do anesthesia anyway. So the atherosclerotic disease is the next cardiovascular disease we'll talk about, well, which we know is chronic inflammation in the arterial endothelium, and usually suggests deposition of LDLs, or lipid-laden macrophage accumulations. They form atheromas, form these calcifications within the vessel wall. Not cool, not cool. The gender factor is, of course, diabetes, increased LDL, low HDL, hypertension, age. There's some gender issues too. Now, family history, you can't shake off those genes. If your father had it, good chance you'll have it. Obesity, sedentary lifestyle, all of those things are important. The end result, of course, is this narrow artery with acute and chronic endothelial inflammation. This is that setup for that atheroma rupture or a vasospasm that the patient goes through, and the lesions are system-wide. The problem is when that vasospasm does occur in the coronaries or in the cerebral or kidney vasculature, more so than the peripheral vasculature itself. How do you treat this? Well, that's the story we'd all like to know. Modify the risk factors, hypertension, diabetes, weight control, blood pressure control, cholesterol control, all of those things. Establish ischemia patients that we know that have atherosclerotic disease, percutaneous interventions or bypass surgery or thrombolytics, essentially trying to clean out the plumbing and changing it out entirely, so revascularization. Medications can help sometimes, beta blockers, nitrates, antiplatelet therapy, statins, etc., etc. The dyslipidemia, the problem with understanding dyslipidemia is that we all understand the differences between LDL and HDL, and sometimes we just don't like it. We just don't like what we get back on our lipid profile test when we get it. But the the atherogenic lipids are the non-HDL lipids, and to understand that, there are two kinds of those, and there's a couple of rat facts in the next couple of slides for you. But the general lipid guideline levels, the older guidelines suggested HDL, LDL, and triglyceride numbers without any reference to age or stratification. But the newer guidelines in 2013 showed that established atherosclerotic vascular disease or any age greater than 21 with LDL greater than 190 is, or diabetics age 40 to 75, or even hyperglycemics, not necessarily diabetics. You want to, LDL of 70 to 189 is considered to be benefited from using statin therapy, and ages 40 to 79 without diabetes or atherosclerotic disease but have a high risk, consider high dose statin for all of these patients. In my opinion, you should order statins for all your patients and probably even consider adding it to the public water supply. Everyone needs to be on it. Everyone could use a little statin in their life. So the new LDL level goals, considering 10-year coronary heart disease risk, LDL greater than 70 is a problem, metabolic syndrome, etc., greater than 100 is a real problem, moderately high, there you go, moderate, moderate, moderately high, and low. I'm going to go over some of these things because we don't necessarily need to know them in relation to how we manage our patients. After successfully having a percutaneous intervention with a bare metal stent, which long-term drug is most commonly used? Is it warfarin? Is it Pradaxa? Is it Plavix? Or is it Xarelto? The answer is Plavix. Percutaneous interventions are an alternate to bypass grafting. This is where they go in and do angioplasty using stents. There are different kinds of stents, as you know. There's a bare metal stent. The bare metal stent usually tends to get endothelialized about 12 weeks or so and can go through the same problem of restenosis and fibrosis after a while. Drug-eluting stents, the drugs that are usually rapamycin or its derivatives or paclitaxel, are usually covered in the stent and over time eluted. That delays the fibrosis and coverage of the endothelium over the stent. The problem with that is that there could be an early or a late thrombosis, much more than the bare metal stents itself. Antiplatelet therapy is usually initiated following placement of a stent, and it's usually aspirin or Plavix. Ideally, dual therapy for at least 1 year or so is given for both bare and drug-eluting stents, but the minimum time of dual therapy for procedures at high bleeding risk is bare metal stent is about 1 month, drug-eluting stent is about 6 months, and continuing low-dose aspirin indefinitely if at all possible. So this becomes an issue if a patient has an emergency that requires them to have a procedure right after having placed a stent in them. Cardiac dysrhythmias are usually benign, but it can also be life-threatening. So typically that whole range and spectrum is an issue. Incidence increases with the aging population. It's often undiagnosed, and history of symptoms are important. Now, I recently, about 2 weeks ago, had a patient that had come to see me for placement of some implants and had told me that she had very recently been diagnosed with an atrial dysrhythmia. And she had never had it before, but she'd been having some symptoms, and it was my consultation that prompted her to go to a cardiologist. They did an echocardiogram, they did ECGs, and they found out now she needs to have an ablation of an atrial wall defect that basically is kind of causing this dysrhythmia for her. So know the common dysrhythmias and know the treatment per the ACLS protocols in your office. The problem is diagnosis can be difficult, especially of those wide complex tachycardias, etc., and these can have multiple etiologies. The problem also is that sometimes they have the symptoms, but the symptoms are rather vague. So that could be unexplained syncopes, recurrent palpitations, new onset chest pain, and if you are in doubt, auscultate. Can you hear the rate? And can you tell if it's irregular? Do they have rales? Do they have some peripheral edema? You might be the one catching it. The supraventricular dysrhythmias, for instance, the sinus arrhythmias, the PACs, and the sinus tachs, are essentially benign, especially if well controlled. But the PSVTs and the atrial fibrillations among these can be rather naughty sometimes, and that can be an issue. We'll skip over some of these things here. Again, rat facts that I want you to just have your handouts and they become reference material for you to go back to get to. The issue with atrial fibrillation, for instance, a couple of small things about atrial fibrillation that you need to worry about. So the symptoms are tachycardia and thromboembolism, and the management of that is where we need to understand how things differ. Thromboembolism prophylaxis is important because patients with constant tachycardia can throw these thromboembolic events, and so for prophylaxing them, they are placed on a blood thinner. They're usually warfarin if there is a valve problem, or it could be Pradaxin, Xarelto, or Eliquis. These are drugs that have made their entry to the market relatively in the recent past, but more and more patients are walking into our offices being on these medications. Pradaxa is a direct thrombin inhibitor. Xarelto and Eliquis are direct factor 10A inhibitors. Before Eliquis came in, the way I would remember Xarelto as a 10A inhibitor is because it's got 10A written right there. But so does Eliquis. It's written right there. And those are both 10A inhibitors, and this is a direct thrombin inhibitor. And by those mechanisms, these patients are given the anticoagulation therapy. A lot of these patients are also on a rhythm control therapy for either cardioversion or with antidysrhythmics that they take at home. Rate control initially is to lower the tachycardia, but the beta blockers, the calcium channel blockers, the digoxin, etc., may be within the armamentarium of what they walk into your office with, and those have to be considered when you consider sedation in these patients. What about patients with pacemakers or the implanted cardiac dysrhythmia? So the implantable pacemakers for symptomatic bradycardias treat second or third degree heart block. They also can be used for treating intranodal blocks or bilateral bundle blocks. They're used in patients who have severe neurocardiogenic syncopes and recurrent syncopal episodes, and myocardial or neuromuscular disease within the myocardium, and in patients with heart transplant to catch their bradycardia, which is not uncommon in the heart transplant population. There are different types of pacemakers. There are those that kick in on demand, or they have a fixed rate pacemaker. The older ones, the patients who have had a pacemaker 10 years ago, probably have their fixed rate pacemakers, but most of these days are on-demand pacemakers which discharge a missed beat, or when they're set for a below bradycardia threshold, they kick right in and provide the adequate amount of heart rate. There are single chamber ones or dual chamber ones or biventricular ones, and that essentially is a classification based on where in the heart they reconnect to. So in these patients, they often require, they don't need external defibrillation at all. They are often internal defibrillators. They can cardiovert or pace depending on the kind of models they have. And modern types are often now placed transvenously. They don't even need an incision on the outside to be placed. So these are the types of pacemakers: single chamber, dual chamber, and multiventricular or biventriculars. What should you remember about pacemakers? Don't put them through an MRI, although there are MRI safe pacemakers these days. If your patient has a kidney stone, lithotripsy can disrupt the functioning pacemaker. Other EMI sources, so things like electrocautery, for instance. Some models can be programmed to handle the cautery, and they may have to be deactivated. Otherwise, just use your bipolar. And the bipolar does not allow for the electric current to pass through the patient's body. And so it's easy enough to do with that. And if at all possible, try not to use a Bowie or electrocautery of any kind with pacemakers. So you can use external cutaneous defibrillating or pacing pads. Just keep it away from the actual pacemaker itself. Now this is becomes standard instruction for ACLS about looking for a pacemaker just because of the number of patients that are walking around with pacemakers in our world these days. Talking quickly about cardiomyopathies. So dilative, most common intrinsic cardiomyopathies. Ischemic is the most common extrinsic cardiomyopathy. And common cause, this is a common cause for heart failure. Signs and symptoms for cardiomyopathy typically are tachycardia or other kind of dysrhythmias, rales, ascites, peripheral edema, and is usually treated with digitalis or ablation of the foci or actual transplant to the heart itself. A quick word on cardiac valvular disease: can be stenotic or regurgitant. Two things to remember there. Any of the heart valves can be involved, but the mitral and the aortic disorders are simply more common, and the mechanism is thought to be because they are on the higher pressure side of the heart. The regurgitant kind of valvular disease is usually a congenital malformation, but it could also be because of rheumatic or bacterial origin from a bacteria colonizing the actual valve. The stenotic disease is usually atherosclerotic and can increase with age even in patients without atherosclerotic disease. But in those patients with aortic stenosis, avoid the tachycardia, minimize the afterload. Goes without saying that these can lead to congestive heart failure. Congestive heart failure is essentially an inadequate cardiac output. The heart gets really tired and cannot meet the physiologic demands and the needs. Multiple etiologies: severe vascular disease, severe atherosclerosis, cardiomyopathies of any kind, hypertension, persistent diabetes, and other kinds. Signs of symptoms typically suggest right-sided heart failure shows ascites, caput medusae, hepatosplenomegaly, peripheral pitting edema, and JVD. And the left side causes rales, orthopnea, shortness of breath, and peripheral nocturnal dyspnea. The paroxysmal nocturnal dyspnea. The systemic conditions cause decreased perfusion, decreased urine output, and some delirium. Diagnosis is usually by physical exam followed by an echo, ECG, and chest X-ray, and some of the serum signs, markers can be elevated as well. It's classified usually into bifunctional or systolic and diastolic, or bifunctional classification, the New York Heart Association classification. And typically, if it's an advanced stage, it requires either transplant or simply palliative care to walk the patient along. So we know that ACE inhibitors do improve congestive heart failure, but are they the right management right away? Acutely, it's usually managing the fluid overload and electrolyte management. So some could use some diuresis, give them supplemental oxygen, invasive hemodynamic monitoring. Chronically, treatment can be a major problem and can usually require surgery, including valve replacement, bypass surgery, or transplant surgery itself. ACE inhibitors, calcium channel blockers, beta blockers, and cardiac inotropes are typically used in managing congestive heart failures, but patients can also be placed on pacemakers or other devices to get them going. So some of the perioperative considerations: the older the patient and the audience that we are trying to attract to our offices, the more of them are showing up with well-controlled cardiac failure, for instance, congestive heart failure, for instance, and they will continue to be on their perioperative dose of medications, whether it's an inotrope or a beta blocker. Hemodynamics is important because they are on a precarious fluid balance, so you don't want to be the person giving them a lot of fluids or making sure that they're peeing and not having a lot of blood loss during the case. Cardiology is usually consulted for management of the condition and aggressively treat pulmonary edema should that occur. Chest PT is usually useful as well. Quick word on cardiac valve replacement and some updates on things. There remains the same old mechanical or bioprosthetic valves. The key thing is that regardless of the kind of valve that's being used, patients usually go on an anticoagulation therapy, and that's where we need to be worried about as surgeons. The mechanical valve replacement typically uses aspirin and Coumadin, but and require the INR to be maintained somewhere between 3 and 3.5. Bioprosthetic valves typically add aspirin and Plavix for the first couple of months, especially if they do a transcatheter and as opposed to an open procedure. The bioprosthetic valves, the warfarin is usually only left in place for about 3 to 6 months, depending on the kind of cardiologist you're dealing with. But typically, there is no necessary risk for thromboembolism if you take them off to do a procedure within those 3 months either, as long as you bridge them or put them right back on it. Now, Pradaxa was found to have a higher thrombotic event with prosthetic heart valves compared to warfarin, so it's contraindicated with warfarin, with valve replacement or valvular disease at this time, whereas the 10A inhibitors, Eliquis and Xarelto, don't have substantial studies yet to prove their worth in anticoagulative therapy in cardiac valve replacement. So if somebody is putting them out there on Xarelto or Eliquis, it's purely because they just want to be cool, I suppose. Remember that antibiotic prophylaxis is still a real deal for prevention of subacute bacterial endocarditis, and anything that we do typically causes that. So if you have a 36-year-old diabetic male with a history of bicuspid aortic valve and well-controlled type 2 diabetes, and an anaphylactic penicillin allergy, who's he's a candidate for which therapy prior to routine dental implant placement. So he has allergies to penicillin. Are you going to give him azithromycin? You're going to give him vancomycin? Are you going to give him clindamycin? Or are you not going to give him anything at all? How many people would not give anything at all? So he's got a history of an aortic valve, bicuspid. He hasn't had it replaced. He's well-controlled diabetic. You're just going to do a routine implant. He's allergic to penicillin. Would you give him an antibiotic therapy at all? I wouldn't, because at this point, this guy has no treatment that is indicated. He has a bicuspid valve, but it's not been replaced or anything like that. We don't necessarily have any problems with that. So what truly are the conditions for which antibiotic prophylaxis is indicated? Prosthetic heart valves, including bioprosthetic and homograph valves, a prior history of infective endocarditis, unrepaired cyanotic congenital heart diseases, including palliative shunts and conduits, and a completely repaired congenital heart defect with any kind of metallic or prosthetic device or material, whether placed by surgery or catheter intervention, doesn't matter, especially during the first 6 months of the procedure. Also, repaired congenital heart defects with residual defects at the site or adjacent to a prosthetic device, and cardiac valvulopathy in transplanted hearts. Those are all definite indications for antibiotic prophylaxis. Those procedures that we do, so any manipulation of the mucosa of the upper respiratory tract, including dentoalveolar surgery, but not necessarily local anesthetic injection, except intraligamentary injection. If you give some, those necessarily don't cause any kind of risk of infectious endocarditis. The regimen as of 2013, as you know, is oral regimen is 2 grams of amox or 600 grams of clinda or azithromycin parenterally. If you have to give it, you have to give it 30 to 60 minutes before. Ampicillin 2 grams, cefazolin or clindamycin. So that's cardiac disease. We'll move right on to pulmonary disease. And pulmonary disease is much more common in our offices thanks to our environmental pollutions, environmental allergies, and all the children that walk into our practices with asthma or prescribed medications for asthma without actual asthma itself. So the topics we'll talk about are factors involved in perioperative pulmonary risk evals and therapies to minimize the risks of pulmonary complications, and the factors involved in the management of perioperative bronchospasm, including asthma. Pulmonary complications are much more common and are more frequently reported in our morbidity and mortality after surgery. And there are 2 things to keep in mind. People with pulmonary disease often look way better than they really are. And locating an office on the 2nd floor of a walk-up building still holds out as the best pulmonary function testing process. So if you can get your patient to walk up to your office, they're probably good enough. Asthma. Asthma is a chronic disease of the airways, and it's associated with inflammation and structural change. It's characterized by something that's reversible, the reversibility of the hyperreactive airway, which narrows after exposure to any kind of allergens or idiosyncratic factors, is what you can reverse. It's not a single or a simple disease. It is often induced by an allergen, can be immune-mediated, or could be simply atopic. Exercise-induced, and that's what we usually see. Patients could have nocturnal asthma as a result of their GERD. They could also have asthma induced from NSAIDs they take for arthropathies, for instance. Some patients could have occupational asthma. Some regions of the country where there's an increase in pollen, for instance, or springtime allergies, for instance, can manifest as asthma. There is also a small condition called infectious asthma, and asthma is a really big problem. There's an increasing prevalence of mortality from asthma worldwide. 20 million Americans, 1 in 250 deaths worldwide, 1% of disability-adjusted life years, and severity tends to increase with time. Most patients are never optimized perioperatively, although we'd like to believe that. Perioperative bronchospasm is one of the most common patient-related morbidity, even in patients without asthma that simply have reactive airway disease. So how do you define it? How do you tell the difference between asthma or no asthma? Chronic obstructive disorder of reversible airway hyperactivity causing dyspnea, cough, wheezing, and chest tightness. It's usually diagnosed by showing the reversibility of obstructive lung disease with normal diffusing capacity. And on exam, patients have expiratory wheezing during acute exacerbations with a prolonged expiratory phase. Severe attacks will have pulsus paradoxus, accessory muscle use, and a silent chest. So typically, you have a 19-year-old male that comes to your office. He comes and tells you he's had at least one hospital admission in the last 5 years for asthma. He has a social history of occasional alcohol using, and he uses fluticasone and salmeterol, BID, and albuterol, PRN, for a rescue inhaler. On your exam, he has impacted teeth number 1, 16, 17, 32, and your respiratory exam has normal work of breathing, minimal expiratory wheeze, and you put him on the schedule for surgical extraction of 4 wisdom teeth. Now that's your typical patient. A lot of our patients look like that, behave like that, come with the same presentation. How are they different? Well, they're different because asthma can be classified based on symptoms into multiple entities. And these can be mild intermittent, so basically they have an inhaler that they use on a PRN basis, and they have less than 2 days per week with pulmonary function test less than 80%. Mild persistent asthma is greater than 2 days a week, and they use a low-dose inhaled steroid. Mild persistent asthma have daily symptoms, and severe persistent asthma have continuous symptoms and have oral steroids they take on a routine basis. Now, patients with asthma come to you with all of these medications they take. They either have a short-acting or a long-acting beta-2 agonist like albuterol. They use these discs like Montelukast, or they're basically leukotriene receptor antagonists that basically causes bronchodilation or by decreasing bronchoconstriction. They sometimes can be on corticosteroids, either a PO or IV, and sometimes patients with COPD are on anticholinergic medications as well. So the risk stratification for asthma is key. And is this a patient that goes through activities of daily living and can go through a strenuous activity without the use of a rescue inhaler? Are they somebody that have frequent night symptoms? What is the severity of their wheezing, shortness of breath, cough, and chest pain? How many times have they had to go into a hospital for this? How many times have they had intubations for this? How frequently are they placed on oral or other or inhaled steroids? What was their last anesthesia experience? Did they have a problem coming out of the anesthetic? Were they told they had a bronchospasm perioperatively? All of these things are important. Additionally, especially in children that come to our practice, smoking. not necessarily smoking by the patient themselves, but smoking around them. Secondary smoke is important. Obesity plays a role in management of these patients. Recent upper or lower respiratory tract infections play a role in these patients. Of course, what are you going to do? Are you going to be all over the place? Are you going to take 4/3 out? Or are you only taking out some baby teeth out on these patients? That plays a factor in risk stratifying these patients as well. So in our particular case we just looked at, let's talk about that case. So on inspection, let's try to objectively evaluate that patient. His workup breathing appeared to be normal. Auscultation, he had a little bit of wheezing, usually tends to be end expiration, and decreased breath sounds. Now, we could send patients for pulmonary function testing, which usually is not necessarily practical in our setting. Just to remind you, let's do a memory check on what pulmonary function testing was. FEV1 is the forced expiratory volume in 1 second. FVC is the forced vital capacity. The ratio of FEV1 to FVC is the ratio goes down with asthma. So in a restrictive disease like that, it's going to go down. Pulmonary PEF, or the peak expiratory flow, is the fastest flow rate at any time during the during the forced vital capacity. And then there are the pulmonary definitions of what a residual volume is, tidal volume is, expiratory reserve volume is, and functional residual capacity is. So when we put patients through pulmonary function testing, you're getting a guide as to where they stand to help you risk stratify. This can be done either at home or in a pulmonology office. And most of us don't necessarily have a pulmonary function testing apparatus in our offices, but we do sometimes get tests back for our patients to figure out our risk stratification. There is some usefulness for some preoperative spirometry. Overall, it's not necessarily useful in perioperative management of asthma patients, but the usefulness is in assessing and diagnosing any kind of occult bronchospasms. So if patients come in with unexplained dyspnea, nocturnal coughs, chest tightness, you can predict the response to bronchodilators and also assess resolution of any kind of acute exacerbation in bronchospasms if you use preoperative spirometry. Selective use, though, is probably better. Because it's quick and safe and inexpensive, and you can keep a spirometer in your office, it can be useful in some of our patients as well. So let's talk about the perioperative planning to optimize patients with asthma. So if patients have few asthma symptoms, they have a history of asthma more than anything else, no history of any upper respiratory or lower respiratory tract infections, especially 4 to 6 weeks, use a bronchodilator pre- and post-operatively and have stopped smoking or not been in the area of a smoker for about 2 months. That's your optimum patient. I typically have all my patients bring in their bronchodilators to the office for the procedures. Those patients that only have springtime allergies that trigger asthma, or have asthma triggered by exercise, which typically means soccer during the summer, and they only use their inhalers once or twice a year, are the ones that you need to be careful about. Those are the ones that never check the expiration date on their inhalers. And those expired inhalers are of no use, especially if they've been expired for about a year or so. And so first thing I do when the patient brings the inhaler in is I check the expiration date on that inhaler, make sure that it's not necessarily expired. And if it's not, I get them to use that prior to surgery. So what are some of the treatment options for our patients prior to surgery? Obviously, that's based on the level of the severity of the disease. Frequently, all that is needed is a short-term setup in the treatment regimen. So what that means is, in controlled asthmatics, for instance, you only may need a short-acting beta agonist just prior to surgery, which is your puffing, couple of puffs of the albuterol inhaler they bring. In moderately controlled patients, especially those that use corticosteroids, along with their beta agonist, make sure that they use it about a week prior to surgery. In poorly controlled asthmatics, if you're especially considering doing the procedure in the office, it so turns out it's a single tooth extraction or something, total waste of time and resources to go to the hospital for just that procedure, you can get in touch with a pulmonologist and try to optimize treatment. Adding oral corticosteroids to the regimen, for instance, has been shown to suppress production of inflammatory cytokines. Continue all medications all throughout the day of the surgery. You can consider adding short-acting beta agonists to existing management, and also preoperative anxiolytics such as midazolam can really assist in mitigating anxiety-induced bronchospasms, and also, not to mention, decreased salivation, etc. The use of systemic steroids within the last 6 months is usually an indication for an IV stress dose of hydrocortisone, dexamethasone, or methylprednisolone. So when the choice comes to choosing a sedative medication for these asthmatics, you typically want to use something that's a bronchodilator. You also want to keep your glycopyrrolate, as expensive as it is these days, handy to minimize your secretions into the airway. You want to make sure their pain is well controlled. You want to make sure their anxiety is well controlled. You want to make sure they're well sedated. You want to make sure that your lidocaine works well, and keep your beta blocker handy, your inhaler handy, just in case you need to use it intraoperatively. Some of the other intraoperative considerations, the overriding goal in anesthetizing that asthmatic patient is to not get to bronchospasm and also reduce the response to laryngeal stimulation of any kind. Propofol is probably a good agent of choice in that hemodynamically stable patient because it can attenuate any kind of bronchospasms and laryngeal stimulations, whether it's an asthmatic or a non-asthmatic, which, as opposed to its predecessor, the Brevitol, which used to do a terrible job with bronchospasms and laryngeal spasms. Ketamine is an ideal induction agent because it does produce direct smooth muscle relaxation and bronchodilation without really decreasing any kind of arterial pressure or smooth or systemic vascular resistance. Intravenous lidocaine has been successfully used to decrease airway irritability, and we see that a lot of anesthesiologists routinely use intravenous lidocaine before induction for that very reason. That's something to keep in mind even in the office. So at the sign of intraoperative bronchospasm, usually you notice a change in capnography and the patient starts wheezing. I've had an intraoperative bronchospasm. It's not necessarily a pleasant event at all. Deepening the plane of anesthesia is quite useful. That's the first step you want to do. You want to kind of deepen it out, primarily because inadequate depth of anesthetics is usually a common cause for bronchospasmicity. Get your inhaler out, make sure you have the appropriate connectors on, and give the patient some inhalation of your beta-2 agonist. Keep your epinephrine, IV or nebulized ready, and be ready to prepare to intubate the patient or start a surgical airway. The problem with asthmatics is that wheezing can get worse during the procedure and certainly go into bronchospasms, easy to go into laryngospasms, and status asthmaticus can be a real problem to manage in the office especially. That could be a slippery slope. What about postoperatively? Postoperatively, obviously the course is dictated by the intraoperative findings and management. If the surgery was unsuccessful, for instance, if you were not able to complete what you need to do, then you should probably stop, manage the pain, and control everything else, and maybe discharge home. But if everything went well, that should be the same case as well. In the setting of significant intraoperative complications like either a bronchospasm, which you were able to manage in the office, or a laryngospasm, which you were able to manage in the office, make sure that either admit the patient or ensure patient safety during travel back home. That's quite important. Much more dangerous than the asthmatic child in the office is these patients that present with chronic obstructive lung disease, or COPDs. This is the disease that is usually common in the older patient, a disease that is characterized by airflow limitation that is not fully reversible, unlike asthma, And the airflow limitation is usually progressive and associated with an abnormal inflammatory response to lungs and noxious particles, or including anesthesia gases. There's only really two conditions we need to worry about: the blue blotter and the pink puffer. The pink puffer is a chronic emphysema patient. They have enlargement of air spaces distal to the bronchioles and have wall destruction of the actual lung parenchyma. But then the chronic bronchitis patient is your blue blotter, who has chronic productive cough for 3 months in 2 consecutive years. Majority of these patients have a combination of these conditions. In the emphysema patient, alpha-1 antitrypsin deficiency has been identified. A lot of patients have smoking associated with the condition and can sometimes be congenital. In the chronic bronchitis patients, there's an increased mucus cell and impaired immune function in addition to the chronic inflammation that these patients have. There is a classification of these patients, and this classification is also a risk assessment or risk stratification of these patients as well. Somebody in a stage 0, for instance, these stages are based on post-bronchodilator FEV1s, and somebody in a stage 0 is at risk and has some risk factors and chronic symptoms, but a normal spirometry, whereas somebody with stage 4 has very severe disease and is at high risk for management intraoperatively. In addition to getting a history about this, I think examination plays a big role. As a part of the history, we should also look at functional status and the activities of daily living and how those are affected in these patients. But on exam, a lot of these patients have the classic barrel chest. They purse their lips and they have decreased sounds. Those are the pink puffers and blue bloaters. And then when you look through chest x-rays, you find that there's a decreased loss of the lung markings. They're hyperinflated and their diaphragm is essentially flat. ECGs can show P waves in 2, 3, and AVF and R axes. R axis shifts is seen, poor R waves, less voltage, QRS in the left precordial leads, for instance. ABGs suggest hypercarbia and hypoxemia, and the PFTs show FEV1 is decreased and no change in the vital capacity, but there's a decrease in the FEV1 to FVC ratio, significant decrease in that. They are managed usually with medications and systemic steroids, oxygen, for instance. Lung transplants are considered in these patients. Pulmonary rehab is a big deal. A lot of patients have trouble quitting smoking and usually is a futile exercise in trying to rehab them. The problem is that with the perioperative exposure, COPD is often exacerbated. There is an increased work of breathing, pulse oximetry is decreased, and ABGs show hypoxemia and hypercapnia. Treatment typically means that they need to be on prolonged nasal cannula or face mask oxygen, anticholinergic therapy, nebulization, systemic corticosteroid therapy, or intubation. Intubation is often a double-edged sword for these patients because the more they get into that cycle of things, the harder it is for them to come out of that. So while you would think that getting a patient with COPD, the safest thing is to do the procedure in the operating room in an intubated setting, that's not always the case. That's not always true. Often what happens is that these patients find it difficult to get extubated afterwards. So if there are staging, so one good strategy to take, for instance, if it's a patient with multiple procedures that need to be done in the oral cavity, so several extractions, for instance, perhaps local anesthesia is the way to go, and stage the procedure and break it up into multiple little units and do it that way, as opposed to exposing the patient to general anesthesia. So if the 75-year-old presents for office-based procedure, he smoked 2 packs per day until about 3 weeks ago. He's not a smoker anymore because he was in the hospital for pneumonia. He was able to get off his smoking, but he has a past medical history of COPD. He uses Proventil, which is albuterol, and Atrovent, which is ipratropium, and is on prednisone since the time of his discharge. His recent labs at the time show hemoglobin's high, hematocrit is high, ABG is listed there, SpO2 is 90% on room air. So what do you need to know? If this guy comes in and he needs to have an office-based procedure in your office, are you willing to sedate him? Should this case be truly managed in your office? Do you understand his disease? What are those medications being used for? Can you stage his disease? Is the patient on nasal cannula oxygen at home? Is he at his optimum function right now? Is any further evaluation needed? And what are some of the perioperative concerns? Remember, he recently got diagnosed with pneumonia and was in the hospital 3 weeks ago. So to answer those questions, maybe the first question to answer is, should we do this in the office at all? Are elderly patients with apparently end-stage COPDs good candidates to undergo an office-based procedure? What about the rest of him? What are his mets? Pulmonary complications are most frequently reported causes of morbidity and mortality after surgery or anesthesia. We know that. But he was just recently in the hospital for pneumonia, and he stopped smoking 2 or 3 weeks ago. So if you consider all of that, yeah, he did stop smoking, which means that in the last 2 weeks or so, he's had some ineffective sputum removal and probably has a lot of sputum left over in his coffers in his lungs right now. Is he really cleared of all his lung infection? Is there a positive response to using his inhaler? And what's his activity index now, and how is that different from before? What will happen if you give him a high-flow nasal oxygen intraoperatively? It's going to decrease his ventilatory drive and increase his VP mismatch, right? So perioperatively, if you do choose to do him in the office, make sure that he lays in a supine position, or should he? That's going to be a real concern too. You should be concerned about the respiratory depressants that you are going to give him during your sedation. Make sure that we don't give him any long-acting neuromuscular blockers. And in surgery, is it going to be less than 3 hours? How will taking oral analgesics affect his ability to perform pulmonary toileting afterwards? With stage 3 disease that he has, is there a high incidence of complications after? Yes, there is. So back to the office. Are you really going to treat this man in your office, or are you going to take him to the hospital? I think I would treat him in the office. I'd treat him in the office because I know he is just released from the hospital. He's probably likely to be buffed at his best. I would use a sprinkle of sedation, maybe show him a little midazolam or something, and inject a little lidocaine in his IV. I would definitely use a lot of local anesthetic. I would do him in the office, but maybe I would only do him under local anesthesia. Maybe I won't give him any sedation at all. Or maybe I'm going to not do him in the office. I'm going to do him in the hospital setting under monitored anesthesia care. Now, if you've been to the hospital and if you've had anesthesiologists do sedation for you, they're the worst at it. They don't know how to do monitored anesthesia care, and definitely don't do it the way we prefer them to be. And, of course, the other option is no, I would only do him in a hospital setting under general anesthesia for total respiratory control. And I don't think I would do that. I think of all these 4 solutions that we have presented here, probably the safest thing for him is to do him in the office under local anesthesia. And that's what probably we should do. So that's our respiratory slides, and we're moving on to GI. There's a lot of things to talk about GI, but we're only going to focus on a couple of small things and how hepatic disease necessarily affects our post-surgical patients. But in your handout, you will have details on GERD, you'll have details on IBD, of course hepatic disease and liver failure, and how bariatric surgery or malabsorption syndromes affect our patients. So I'm going to go over some of these things here and quickly get to liver disease. Hepatic disease. Liver functions, as we know, are blood glucose regulation, protein metabolism, lipid metabolism, hemostasis factor synthesis, and bile production. It also breaks down hemoglobin and also takes care of the drugs, toxins, and hormones we throw at it. Hepatic disease can be drug-induced, which could be primarily acute or chronic. Could be chronic as in drug as in alcohol-induced. Could be bacterial or viral, and it could be autoimmune. In the autoimmune in that criteria, could be primary biliary cirrhosis, or it could be primary sclerosing cholangitis. Primary biliary cirrhosis is an autoimmune bile duct sclerosis with cholestatic cirrhosis, whereas in primary sclerosing cholangitis, that's an autoimmune condition that causes bile duct inflammation with sclerosis and cholestatic cirrhosis. So which viral hepatitis is the highest incidence for liver failure? Is it virus A, B, C, or D? And the answer is actually D. Viral hepatitis is highly infectious. Viral hepatitis A is usually contamination of food that causes that. It's generally self-limiting. You throw up for a couple of times, you have a stomach flu, it goes away. Hepatitis B virus is a DNA virus and can survive up to 7 days on surfaces. It's usually consumed in the parenteral route. It's exposed in the parenteral route. It does have a classic serum marker progression. 5 to 10% of infected adults can become chronic carriers. The best treatment, of course, is vaccinations we got in dental schools and colleges and the post-exposure prophylaxis protocols per CDC. What about hepatitis C? That is an RNA virus, and it is transmitted parenterally. Its lower infection rate after exposure than B itself, but its acute infection is often asymptomatic in about 70 to 80%. It's a higher conversion to a chronic status in 75 to 80% of patients, and the higher incidence of hepatic dysfunction, cirrhosis, and hepatic cancer up to 5% of the patients who have hepatitis C. There is a Hep C vaccine, but there are many problems with that. There are multiple genotypes of the virus itself, and it seems to be dodging us because of its fast mutation abilities. So it's hard to catch the virus. It's difficult to get effective traditional antibody-stimulated immunity in these patients. The focus, of course, is stimulation of T-cell immune arm by the attenuated viral antigens in managing this condition. So hepatitis C treatment regimens undergoing rapid change based on what we have found as well. There's a number of new oral antiviral agents that have been approved in the last couple of years. The trend now seems to be multiple oral antiviral regimens, usually at least 2 of them at a time. And the exact regimen, of course, depends on the genotype of the 6 major genotypes of the virus itself. The trend is towards using less IV medications and thus expecting less side effects. The problem is there's a high conversion to there is a high conversion to negative viral loads, and the problem is that the expense of the cost of treatment can be really high. There is a hepatitis D. It is also an RNA virus and can only propagate with Hep B infection. The greatest incidence of hepatic cirrhosis and cancer, and the treatment is along with the vaccination against hepatitis B. Hepatitis E is an oral fecal transmission route similar to hepatitis A and is generally self-limiting. There's a lot of nice information on the CDC website for health professionals on hepatitis if you want to share that with your staff, for instance. What about alcohol-related hepatitis? What are the chances that an occasional drink that we have or enjoying the single malt scotches can give us alcoholic hepatitis? The clinical findings with alcohol abuse is typically hepatomegaly, ascites, caput-medusae, and splenomegaly. There is also testicular hypertrophy, gynecomastia, muscle wasting and malnutrition, peripheral neuropathy, and encephalopathies. It can be acute, and liver failure can be acute, associated with either drugs, alcohol, or actually an infection. It could have variable recovery, but even an acute liver failure can lead to possibly transplant. Chronic liver failure, for instance, usually there is a gradual replacement of hepatic lobar tissues with fat and connective tissue. Typically, for every hepatic hepatocyte that is lost either by toxins, drugs, virus, or whatnot, the amount of replacement in the natural system is so heavy that for it usually to get to a chronic cirrhosis level requires a lot of destruction of hepatic lobar tissue and hepatocytes. The problems associated with liver failure is the fact that drug metabolism and dosing has to be adjusted to that. Coagulation factors are affected, and so bleeding could be an issue. Portal hypertension can affect your perioperative management of the patient. Immune dysfunction, which comes hand in hand with liver failure, can cause problems in the postoperative phase. Of course, encephalopathy can in itself be a problem. There's, of course, the hepatorenal syndrome, where the acute renal failure is caused by acute or chronic liver failure and has a high mortality rate associated with it. So there's the model for end liver disease, or MELD score or classification system. General MELD elective surgery rules is greater than or equal to 10 or greater than 15, less than or equal to 10 or greater than 15. This is for the residents, for instance, this is something that could come up in your OMSITE and daily pimpage at rounds to understand what the scoring system in liver failure is. So at least have the MELD score handy when you talk about patients. So what are the contraindications for elective surgery when patients have liver disease? So the risk of surgery in patients with liver disease is in patients with acute alcoholic hepatitis all the way through severe chronic hepatitis. And when it has renal failure and cardiomyopathy and hypoxemia associated with that, all of these factors contribute further to contraindicating elective surgery in patients with liver disease. We'll go through this quickly so we can get to the next level. The use of liver function tests on routine basis in our ambulatory anesthetic setting is not necessarily pertinent at all, and it all relates to the level of the liver injury and the level of the liver failure and how it affects our management of our patients in our practice. Which pain medication is less effective in advanced liver disease? Is it meperidine, is it morphine, is it tramadol, or is it codeine? And the answer is that it is codeine. Which pain medicine is most problematic in hepatitis C-related advanced hepatic dysfunction? Is it naproxen, is it acetaminophen, is it meperidine, or is it tramadol? The answer is it's naproxen. The problem with those two drugs is that pain medications and liver disease are connected. Opioids in general have a higher free blood level, and most have increased clearance time. Lower albumin can cause decreased protein binding in a high free drug level, which means decreased dosing and or increasing dosing interval is indicated in liver disease. Patients with opioids with active metabolites such as morphine and meperidine have to be particularly mindful giving these to patients with liver disease. Because codeine is a prodrug and requires oxidation to active metabolites for its effects, it is less effective in liver failure, and that's also to consider the fact that if you add acetaminophen to that, that can cause further liver disease as well. Acetaminophen is generally considered safe in the chronic non-alcoholic category of liver disease, when the usual recommendation is limited shorter duration. Alcohol induces the CYP450 system, so avoid with alcohol hepatic disease in using Tylenol. NSAIDs, what about NSAIDs? Can you give NSAIDs in liver disease? You probably shouldn't, because it increases the bleeding risk, increases renal toxicity with hepatic failure, and decreases diuresis in ascites. So that's a real problem with that. How about antibiotics? In patients with liver failure, augmentin, there's some concern with using beta-lactams and penicillin-resistant penicillinases and newer generation cephalosporins. Macrolide, it's because macrolides are cholestatic, avoid those. Quinolones are generally safe except trovafloxacin, which can cause some liver toxicity as well. Sulfonamides are immune toxic, and so probably not a good idea to throw that on top of liver disease. Tetracyclines and minocyclines avoid some because of the immune toxicity that they cause. The other drugs, the other antibiotics that may increase liver toxicity but may or may not cause liver function tests can be used with some caution, include metronidazole, clindamycin, and these listed here. When a patient presents with liver disease, be on guard that everything will be affected with the drug metabolism, and if in doubt, you probably have to err on the side of caution and consult a hepatologist or a clinical pharmacist to take care of these patients in conjunction with what you normally do. So this was where I had planned a break, but since we are going straight to lunch, we'll hit renal disease and then finish up with hematology a couple of times. Renal disease, disease of the kidneys. So here's your 54-year-old patient that comes in with an edentulous posterior maxilla. He wants implants. He has chronic renal failure and hypertension, takes Lasix, an ACE inhibitor, potassium, and metoprolol. Are you going to sedate this patient in your practice, or are you going to move forward to a hospital to do what you need to do? So let's try to understand chronic renal failure. There's some rad facts about chronic renal failure there. The most important thing there is to understand that proteinuria is a predictor of disease progression in these patients. Rad facts, complications in renal failure include anemia because of the depletion of the erythropoietin stores. Renal osteodystrophy can be a real problem in patients with fractures, for instance, when it comes to healing. Hyperkalemia can be a problem when you consider sedation in the office. Same with sodium metabolism, pericarditis, and dialysis-related infections in patients. So your patient comes in, he's got a posterior edentulous maxilla, and his blood pressure is 165/100. The surgical plan for you is to do your stage 1, you want to do some bio-Oz and BMP and do a bilateral sinus lift. Stage 2, you're going to do 4 dental implants. What are your concerns in patients with chronic kidney disease? The problem is that chronic kidney disease can be associated with excess surgical morbidity, and the most important of which include acute renal failure, hyperkalemia, volume overload, postoperative infections, drug metabolism, and intraoperative and postoperative bleeding. Associated morbidities associated with that are hypertension, coronary artery disease, and cerebrovascular accidents. A lot of patients go on dialysis, whether that's hemodialysis or peritoneal dialysis or fluid replacement therapy, renal replacement therapy, or that's done on an ambulatory basis. What do you look for to assess renal risk stratification and renal function? Renal function is usually a function of how these play out, your serum creatinine and urea, electrolyte balances, bicarbonate, hemoglobin, and hematocrit, and of course you have an app now to calculate your GFR quite easily on your smartphones. Let's go back to our patient and tell you the labs on this patient. His urea is 31, his creatinine is 24, his sodium, potassium are 142 and 5.1, his calcium is 9.5, his bicarb is 20, his hemoglobin is 12, and his crit is 36. What's his renal function? Probably at about 90%, 75%, 50%? I think it's about 25%. All right. Now that we have measured the renal function, how do you want to stratify the risk? Now remember, your renal doctors can tell you that as well. And sometimes patients who know that, who see a renal doctor, a nephrologist, often will come back and tell you, well, my renal function is only at about a quarter of where it should be. And so you have that information. How are you going to manage that? You need to understand that patients with renal disease also come with other baggage, and that goes back to the same thing with risk stratification of any disease process. Do they have hypertension? Do they have coronary artery disease? Do they have cerebrovascular insufficiencies? What is their history? How long have they been a patient with renal insufficiency? What's their functional status? What are their vital signs? What do their ECGs show? Is there any acute coronary disease that we're capturing? Is there ischemia? Is there electrolyte-induced changes on the ECGs that we know? So functionally, we figure out he's got greater than 4 meds. His blood pressure is 165 over 100, and his ECG has no acute changes. So how many in the audience would actually consider doing a bilateral sinus lift and implants on this patient in the office? Not one of you, and nor would I. I would not take this patient and sedate him in the office to do this either. Now, for argument's sake, if we said that this patient actually needed to have a surgery, and he had bilateral mandible fractures and needs an ORIF, what would our perioperative concerns be? Our major perioperative concern should be the fact that we need to be worried about and be focused on his volume status in the light of his renal disease and decreased GFR, and hypertension and its management perioperatively. He may have metabolic acidosis, which is compensated. He's anemic, and that means that we may have to manage some of that in the perioperative phase. Acute renal failure, probably causing some interstitial nephritis, and how we prevent that. Uremic bleeding, cause some, maybe think of some local measures, use some DDAVP, and probably postoperatively even worry about antibiotics because of his immune status. If we needed a CT on him, obviously we can't get a contrast because of his renal status. We have to worry about IV fluid replacement without any potassium. We have to be bothered about his hyperkalemia and what that could do intraoperatively and postoperatively. Remember, his ECG didn't show any changes, but it could. Calcium's high, and keep some KX-late, insulin dextrose, dialysis, and all of those things ready, just in case we have to deal with the hyperkalemia. And intraoperatively, we need to avoid nephrotoxic drugs. A lot of the medications we give, including nonsteroidal anti-inflammatory, some of the antibiotics may be nephrotoxic. And the renal dose of medications is important. Patients with end-stage renal disease require dialysis right after the procedure, and we have to kind of plan the procedure in such a way that it's between the doses of their dialysis. That can help with elimination of some of the overdosed regular drugs that we give them. Postoperatively, nutrition is not to be excluded, and we should worry about making sure that's all well controlled and the patient receives a low protein diet. If this patient's being chronically dialyzed and need to have 3 teeth taken out in the office, your plan should include, so here comes the management of office-based surgery in patient on dialysis. Obviously, we know to do the procedure on a day in between. That hasn't changed. No IV or BP in the arm with the AV shunt. Anticoagulated for dialysis, so we need to keep that in mind. Prophylactic antibiotics. How many people give antibiotics for prophylaxing the dialysis port? Nobody does. I'm the only one that does. So the problem with that is we don't have consensus on that. The worry we have is that staph or skin commensals can be the issue. And typically, I don't use vancomycin. I just give oral prophylaxis of medications. There is no current consensus on prophylaxing patients for AV shunt infections at this time. So would you perform surgery on a patient on hemodialysis in the office under local, in the office under IV sedation, or in the ambulatory hospital center under GA or monitoring anesthesia care? How many people would sedate patients on dialysis? Nobody. Oh, maybe. Nothing wrong with that. If you can, plan out and stratify that, that's fine. But most people would, I think, either go to the hospital or consider doing local only. If you do consider doing an office-based procedure, understand that midazolam is metabolized in the liver but excreted by the kidney, so it could hang around a little bit. Careful initially dose, profound and prolonged effect is the problem. Fentanyl is metabolized in the liver, and clearance is reduced in patients with BUN greater than 60, and it's poorly dialysable, so it does stay in the system even after dialysis. Propofol is metabolized by the liver, and there's no evidence that it changes anything in end-stage renal disease. Now, with the transplant programs getting more and more boost in the arm and technology coming along and surgical skills getting better and better, we are seeing more and more patients, post-transplant, pre-transplant, all kinds of transplant-related patients come to our practices. It's important to figure out where their immune status is, and so CBC is probably not a bad idea. Continue all their immunosuppressants all the way up to surgery, and then if they have adrenal suppression, probably usually supplemented that by using long-term corticosteroids. There is a paper out there that says prophylactic antibiotics and preoperative chlorhexidine is generally beneficial in patients that are post-transplant to prevent postoperative infection after minor oral surgery. The general principles, though, that we learned in combination is the fact that in drug therapy in kidney disease is to understand that drug toxicity remains an important cause of morbidity. Drugs that are renally cleared usually accumulate, and their dose and frequency must be adjusted to that. But the problem is there's varying levels of kidney function in all patients, and that's hard to figure out preoperatively. Drugs cleared by the kidney may be metabolized into conjugate moieties that can accumulate and have activity or side effects such as morphine or procainamide, for instance. So we know that decreased absorption through the GI tract does occur because of concomitant use of phosphate binders in patients with kidney disease, and that particularly is the case with Coumadin and other immunosuppressive drugs. Volume distribution of drugs is altered in kidney failure because of altered protein binding, especially in digoxin and phenytoin therapy. And appropriate dosing of drugs requires an estimated creatinine clearance, which requires 24-hour urine and creatinine levels, which are not good indicators anyway. So the drug therapy, there's a good reference that I put in there. It's old, but it hasn't come back. They haven't updated it in a while, so we still go back to using the same references because I guess kidney disease hasn't changed much. Most induction agents have altered protein binding, and the dose should be reduced in patients with kidney disease. Most muscle relaxants are partially or completely cleared by the kidney. Sux, for instance, can result in more hyperkalemia. Etricurium is not cleared by the kidney and is probably the drug of choice in patients with kidney disease. Inhalational gases such as enfluorine and sevoflurane are contraindicated because of fluoride-induced renal failure that they can cause. However, isoflurane and desflurane and halothane are better tolerated, although I think it'll be difficult to ask for halothane in the OR these days. Propofol is safe to give. Fentanyl and sufentanil is safe, but elimination is reduced, and so effects can be prolonged. Remifentanil is probably a really good choice in these patients. It quickly gets eliminated. Half-life of drugs used to reverse anesthesia are prolonged, and doses should be reduced, whether it is neostigmine or ephedronium. Pain management. So both morphine and meperidine are contraindicated in end-stage renal disease. Morphine because it just hangs out and is usually cleared by the kidney, same with meperidine. So that's kidney disease for us. I have a couple of things on endocrine diseases, but we'll stick to things that matter. So diabetes and thyroid diseases. I'm going to skip on the thyroid disease and talk about diabetes. Which of the following is the most useful for monitoring long-term glycemic control? Is it urine glucose? Is it serum glycosylated hemoglobin? Is it fasting serum glucose, or is it oral glucose tolerance test? We know that it is the glycosylated hemoglobin or hemoglobin A1C. The excess of serum glucose in diabetes usually is because of absolute insufficient insulin, which is a type 1 type of diabetes, and the relative insulin insufficiency usually because of insulin resistance by peripheral tissues and or insulin deficiency, which is a type 2. The classic symptom triad is the polydipsia, polyphagia, and polyuria in these patients. Just to recap, insulin is that peptide hormone that is produced by the pancreatic beta cells. There is a negative feedback involving the serum glucose level into creation of insulin, and the action, of course, is to promote glyconeogenesis and triglyceride synthesis, and hence decrease the serum glucose levels. It also inhibits glucose levels by suppression of gluconeogenesis, glycogenolysis, and proteolysis or lipolysis. So the lack of insulin delivered intracellular glucose causes lipolysis to keto acids, which can be used for cellular energy production as in starvation, but causes pH derangement or ketoacidosis. 10% of all diabetics are type 1, and they have a relatively young cohort. Usually type 1 we talked about is lack of insulin, acute problem being DKA or diabetic ketoacidosis. In diabetes type 2, that's insulin resistance by liver, fat, muscle, etc., they may have a component of decreased insulin secretion in addition to the resistance. They are older patients. Overall, 3/4 of the type 2 patients are obese or at least hyper or overweight. And the acute problem is non-ketotic hyperosmolar coma, which high serum glucose concentrations cause increased serum osmolarity, dehydration, and thus a coma. So we're going to skip over some of the things with diabetes and get to the anesthesia-related issues with diabetes. So we do understand that diabetes does cause some anatomic changes. Gastroparesis, for instance, is a real issue. All diabetics needed to be treated as full stomach, and that potentially creates a problem because you have to give them extended NPO times, and they cannot necessarily tolerate hypoglycemia as well. So we talked about the cheloarthropathy and the prayer sign and the stiffening of the neck, limited TMJ, and obesity. And we'll talk about obesity here in a minute. Going to skip over. The silent myocardial ischemia is common in long-standing diabetes. It's usually because of a diabetic neuropathy that the MI is silent. You can have other ischemic symptoms such as shortness of breath and fatigue and ECG symptoms, for instance. Diabetes is a pandemic for us, and we have about 25 million or almost 26 million, about 8% of our population have diabetes. There is an increasing number of pre-diabetic children in our population in the United States, and that's assuming that over 7 to 10 million of them remain undiagnosed. Huge problem. The diagnostic criteria obviously is the fasting plasma glucose and oral glucose tolerance testing, and then random plasma glucose testing as well as the hemoglobin A1C. Prediabetes is a condition that is described well that goes on to becoming diabetes. Diabetes screening includes starting at the age of 45 with risk factors of obesity and family history, and the current retest recommendation is fasting serum glucose and hemoglobin A1C every 3 years until you hit the target of actually becoming a diabetic. The pre-surgical workup includes figuring out the type of history, the type of follow-up, the type of frequency of serum blood glucose, and the most recent hemoglobin A1C. And of course, there's the treatment of diabetes for type 1. I won't go into the details of the insulins and the types of insulins and the current fad of using insulin pumps. They've become better and better. They've become programmable, and there are these subcutaneous blood glucose monitors that have become available, and they are also implantable, and they kind of self-regulate along with a subcutaneous infusion pump, creating essentially an artificial pancreas. So this is going to be the next generation of management of type 1 diabetes. Type 2 diabetes, understand the importance of drug therapy as well as diet modification, exercise, and weight reduction, and there's mono or dual therapy. And currently the newer hypoglycemic agents that are getting into the market now require a little bit more attention this morning. That most of these inhibit proximal tubal glucose reduction. And what the FDA has approved 3 basic drugs. There's Farxiga, there's Invokana, and there's Geridance. Invokana has become a little bit more popular as a SGLT2 inhibitor. They are heavily advertised, but at this time considered a third-line drug for glycemic control and used with other hypoglycemics. It does decrease hemoglobin A1C and cause some weight loss, but can cause and will cause some glucosuria, which can skew off your urine analysis results. Less hypoglycemic episodes, much more than more traditional hypoglycemics at this time. Let me ask you this, just to keep you guys awake. What is your threshold of blood glucose that you would consider deferring elective surgery? Would you defer elective surgery if somebody showed up with a blood glucose of 275, 325, 375, or 425? How many people would defer surgery at 275? Elective surgery. Good. What about 325? Yeah. 375? Oh, everyone would do surgery at 375. Okay, what about 425? I wouldn't do surgery about 325, and I'll tell you why. Because at about 300 to 350 is when the stress neuroendocrine response will raise the blood glucose even higher. And once it's past 400, osmotic changes happen. Insulin will take its time to effect and nothing will work if you try to do things at that time. How does surgery affect diabetes? It causes stress, of course, increases the blood glucose. There are other hormonal responses such as, all of these things, glucagon, proteolysis, epi, all of these increase blood glucose. Hyperglycemia is additive with glucose intolerance, and using perioperative glucosteroids can also further increase blood glucose. Perioperatively, your management goal should be normal volemia first and foremost, and relative normal glycemia. Relative because, for some patients, you don't want to lower it too much. You also want to keep an eye on your electrolytes, and you want to make sure the determinants of therapy based on invasiveness of the procedure, duration of the procedure, and type of anesthetic that the patient's getting. So local anesthetic is probably just fine to do what we need to do, but then if patient's really anxious, that's not really going to help either. So maybe a little bit of sedation is probably a good thing. The Society for Ambulatory Anesthesia has provided a statement on perioperative guidelines, blood glucose management in diabetic patients undergoing ambulatory therapy. And a part of that includes management with non-insulin oral hypoglycemics, basically suggesting that they continue on all normal scheduled pre-op, possibly skipping PM metformin, nothing to be taken on the day of surgery, consider extended fast pre-op, so because the gastroparesis and the full stomach consideration. Perioperative blood glucose monitoring, DCing metformin, 24 to 48 hours before surgery, only with renal dysfunction and with anticipated IV contrast use, which is not really something that we need to worry about. In patients with insulin, minimal alteration to the basal insulin control is probably best. Some alteration to intermediate acting insulins to avoid hypoglycemia, especially when you have the patient's NPO. No rapid or short-acting insulin perioperatively, and no non-insulin injectables on the day of surgery, and of course check your blood glucose before and after and during the procedure. So this little chart in your handouts will give you a good clue as to which way to proceed with management of outpatient insulin on the day of, the night before, etc., etc., and usually gives you a good idea on how to manage long-acting and short-acting and intermediate-acting insulins. So the guidelines from SAMBA, what we currently use in the anesthesia, or in our outpatient anesthesia. Now, if you don't have the handouts, which I have provided the handouts have 680 plus slides, and it's a detailed textbook if you want to use it that way. But I would suggest that you ask Joe Kearns for a set of handouts. I think you should try to get them, because the part of the presentation I'd make is only 1/4 of what I will give you for the handouts. I'm going to get past all of this stuff. Not going to talk about thyroid disease as much, other than the fact that Oprah Winfrey had thyroid disease and everyone suddenly got on the thyroid bandwagon. It really has a few key points that we need to remember from a perioperative management perspective. Some of this is the details of how I studied for my boards, for instance, when it comes to doing thyroid exams and thyroid. That's a hairy chest, my God. All right, keeping on. None of the thyroid function tests or thyroid studies are really of any particular relevance to the ambulatory oral maxillofacial surgeon. However, be aware of the condition of hypothyroidism and myxedema and cretinism, because it does have some bearing on how we manage our patients. The primary hypothyroidism as well as a hyperthyroidism has to be at least diagnosed in the at the outset and taken into consideration when you give patients anesthesia, and primarily for this, because when there is a patient with hypothyroid, imagine that there is a macroglossia associated with the myxedema, and that can associate itself with an airway embarrassment. Cold insensitivity, increased anesthetic sensitivity, decreased respiratory drive, decreased blood pressure, relatively high incidence of adrenal suppression, and so probably these are the patients that could benefit from having a steroid in their IV during a procedure. Hypothyroidism can sometimes be a little bit more common in a teenage population more than an adult, and so it's something that in your examination, in your review of systems, you might be the first one to catch this. And there's a spectrum of mild to significant thyrotoxicosis associated with these patients. They go into hypermetabolic states, and patients with Graves' disease or Hashimoto's disease, for instance, can be a real problem. There is the toxic thyroid toxicoses can also be related to a viral gland infection or multinodular goiters. Multinodular goiters also can get in the way of airway examination, and you have to keep in mind that those patients could be difficult airways, not just necessarily from the fact that it might be difficult intubations, but also in case you have to do a surgical airway, that goiter is going to be all over the place. A quick note about cocaine and amphetamine overdoses and aggressive psychologic behaviors associated with these patients. Some of these younger folks that have underdiagnosed hyperthyroid disorders can particularly be a challenge during sedation in the office and could have hyper-aggressive psych disorder, if you would, and their behavior could be affected by this. So keep that in mind as in your differential diagnosis associated with this. So there's the details about treatment. I'm going to finish up the morning with talking about obesity. Let me ask you, what % of U.S. adult population do you think is obese? I want to say it's 35%, and I think it is correct. I think children and adolescents, about 15% of our population is obese. Can you imagine? And 35% of us are obese, not necessarily just overweight, but obese. The problem is that this presents itself in multifactorial, multisystemic variety of challenges in the office. There is a 4 times likely chance to develop intraoperative or postoperative pulmonary complications in the obese patient. Obstructive sleep apnea is undiagnosed in 80% of patients with this condition. Cardiovascular disease, GI system, diabetes, stroke, you name it. Altered airway is a real concern, decrease in cervical and mandibular range of motion. Thyromental distance is altered, less favorable malymphatic classification, more likely to collapse during anesthesia, and like I talked about, that pharyngeal pannus, everything's out there. So the altered airway is a real concern. Patients that are obese are more susceptible to hypoxemia, decreased FRC, increased closing volume. They have an increased work of breathing. They essentially have a restrictive lung disease and have a constant ventilation perfusion mismatch. The cardiovascular pathophysiology changes in obesity as well. 50 to 50% mild to moderate hypertension in these patients. About PVCs are very high, about 10 times higher in the obese population than the control group. Myocardial hypertrophy, left ventricular dysfunction, coronary heart disease, and congestive heart failure is not uncommon. GI system, increased risk for aspiration, high residual gastric volume, low gastric pH, and an increased incidence of hiatal hernia. Now, if you ever wondered how you can calculate these, again, there's an app for this as well. Don't need to worry about. Most electronic health records will calculate the BMI for you based on the input that the staff puts in, so you don't need to worry about calculating it. Usually you're given a number. Anything greater than 35 or equal to that is considered morbidly obese, and we have patients greater than 50. Childhood obesity is a real problem, especially in my clinic for some reason. I have a lot of chunky children that come through. BMI is calculated for all ages and genders, regardless of age and gender. The formula obviously is that, and classifications based on BMI vary with gender and age in the pediatric population. There's a lower threshold for what is normal and abnormal in the pediatric population. So underweight is anyone below the 5th percentile, obese is anyone above the 95th percentile in children. I'm going to skip through some of these things and get to the meat and potatoes. I'm hungry, I'm sure you are too. Obesity, it does relate to morbidity because of atherosclerotic disease, hypertension, endocrine abnormalities, and non-alcoholic fatty liver cirrhosis, also leading to hypercoagulability and their increased risk for deep vein thrombosis and pulmonary embolism. Osteoarthritis is a real problem because these people don't move. Obstructive sleep apnea is a problem as well. Interestingly, with bariatric surgery, we are currently enrolling patients in a study in our clinic to see if their tongue size changes after bariatric surgery. And we're using MRI studies to figure out if the tongue size differs pre-op, post-op, and then correlating that to obstructive sleep apnea. And so far it's been promising that bariatric surgery candidates, those patients who have greater than 40 BMI are candidates for bariatric surgery. Have sleeves, gastrectomies, lap banding, all kinds of balloons and things like that they put in there. And they do well in the sense that it is a complex procedure. It does cause major complications, but patients usually have a full stomach, and the problem is that they still need nutritional support, and so diets after the surgery can be a real problem. Now you have to watch for Honey Boo Boo's mom's coming out after her surgery. She's supposedly looking really hot. I don't know, so we'll see how that goes. I'm going to skip through obstructive sleep apnea here because this is something that we do on a routine basis in our practices, and get to the perioperative management of the obese patient. The obese patient is best treated outside your practice, not necessarily in the office. If you do it, even doing local anesthesia is a problem for these patients. I don't know about you, but my arm span is not very big, and for me to physically get around a large patient to pull a tooth or even give local properly is a challenge. So I prefer that these patients are treated in the inpatient OR setting. I do take up a lot of resources doing that, but it's probably the best thing to do because there are multiple things at play here. Pulmonarily, they continue the CPAP during the case. You got the early ambulation. You have these hoses on, these sequential compression devices. Patients are usually given a chemoprophylaxis, and then of course the positioning is a little better. All of them are padded well. A little bit of tilting helps in getting into their mouths to do what they need to do. It does give them an increased infection risk, but then prophylactic antibiotics help quite a bit. So the last section here is hematologic considerations. It's just about noon. There's nothing in this that is nothing that cannot be learned outside of the handouts there. So I have asked Dr. Kearns if you don't have handouts, I'm sure he can get it to you at this point. So at this time I think I will finish up here, and then in the afternoon when we come back We're going to talk about some pediatric anesthesia, some pearls on whether we can do this in our offices and whether we should truly be doing it in our offices. I don't know, Joe, is there a way for me to take questions at this time?
Deepak, can you hear me?
Yeah.
All right, yeah, so we're going to have lunch from 12 to 1. So I will call your cell when we're getting ready to start, so you know.
Okay, that'll work.
All right. Thank you very much.
See you guys back.
Lunch is next door, guys. Thanks.